Late, we are proceed toward the prestigious Dr. Late V.N. Shirodkar Oration. I request Dr. Amruta to carry forward.
Thank you, Dr. Lalita. After our annual general meeting, a warm and pleasant good morning to one and all present here once again. On behalf of Team SOGS 24-25, I welcome you all for the most awaited, prestigious late Dr. V.N. Shirodkar Oration. Dr. V.N. Shirodkar was a great Indian legend, a veteran, a warm and kind person who had greatest contribution in the field of obstetrics and gynecology. He had medicine in his veins. He was a clinician who brought about revolutionary concepts, surgical methods, fresh insights into the field of obstetric and gynecology. The magnanimous work done by this stalwart is original, path-breaking, and recognized by whole world. I would like to invite the office bearers of the year 24-25 and 25-26 on dais for this prestigious oration. President Dr. Ghate Madam, Dr. Lalita Agarwal, Dr. Chandrakant Zadav, incoming President Dr. Sujata Kulkarni Madam, Dr. Lata Patil, Dr. Snehal Pawar, please come on dais. I would also like to invite chairpersons Dr. Bahubali Doshi sir and Dr. Rajiv Dabde sir on the dais. Every year, this oration is presented to a distinguished individual for his outstanding contribution in the field of OBGY. But this year, we have with us Dr. Chandrakant Kanse, a well-known physician from Pune. He has done tremendous work in the management of diabetes, hypertension, PCOS through lifestyle modification. I welcome you, sir, on behalf of Solapur OBGY Society. I now request our President, Dr. Ghate Madam, to escort Dr. Kanse sir to stage. Thank you, Madam. I request President Dr. Neeta Ghate Madam to present the preamble.
Good afternoon, one and all. Today I welcome Dr. Chandrakant Kanse sir as a guest for Shirodkar Oration this year. Everybody knows that there is no introduction actually needed for Kanse sir, because if you go on YouTube, there are so many lectures on diabetes reversal, hypertension reversal, lifestyle modification on this. Talking about his work, his academic qualification, he is MD General Medicine, Gold Medalist in 1986 from BJ Medical College, Pune. He is PhD Scholar in General Medicine from MUHS Nashik. His professional experience as a practicing physician in internal medicine for last 38 years, practicing diabetes reversal with dietary and lifestyle modification for last 11 years. He treated successfully over 20,000 patients of diabetes type 2 and type 1, obesity, PCOS, hypertension, fatty liver, lipid disorders, etc. in last 12 years. Diabetes Reversal Clinic at PCMC and Elephanta. Teaching experience, he is 24 years as a professor in medicine at Anantrao Kanse Homeopathic Medical College at Alphanta and Taluka Junnar at Pune. He established 3 NGOs, Kulaswamy Medical Foundation, Shivneri Foundation, Anant Charitable Trust in field of education, healthcare and social work. His activities, he organized and actively participated in variety of medical and social camps, diagnostic, medical, diabetes, polio, senior citizen, health awareness, school checkups, women health, homeopathics in last 38 years. Actively participated and in various disasters such as a Killari earthquake, Bhuj earthquake, Kargil war, Kerala Kolhapur flood relief, etc. He himself ran 25-kilometer half marathons with his wife. His awards and recognition: in 1995, Honorary Rotarian Award; in 1996, Paul Harris Fellowship; in 1997, Rotary President Citation Award; in 2012, Sharad Chandra Gaurav Puraskar. Various felicitations in last 3 decades. This is his CV. मला आता मी मराठीतून त्यांच्याबद्दल थोडंसं सांगेन की त्यांनी स्वतःवर प्रयोग केलेले आहेत. त्यांच्या वयाच्या 52व्या वर्षी जेव्हा ते ओबेसिटी, हायपरटेन्शन ह्याच्यानी ग्रस्त होते आणि बेडरिडन होते, तेव्हा त्यांनी स्वतःवर आधी प्रयोग करून स्वतःचं डायबेटीस कंट्रोल करणं, स्वतःचं हायपरटेन्शन कंट्रोल करणं आणि लाईफस्टाईल मॉडिफिकेशन म्हणजे स्वतःच्या आहारामध्ये आणि जीवनशैलीमध्ये असे बदल घडवून आणले की त्यानंतर ते एकदम फिट मेडिकल फिजिशियन झाले आणि त्यांनी ते प्रयोग असे प्रूव्ह करून दाखवले रिसर्चमधनं आणि त्याच्यावर बरेचसे पेपर पण प्रेझेंट केले. आपल्या सर्वांना आपण शिकतो की फर्स्ट इयरला MBBSला शिकवतात की हा प्रोटीन मेटाबॉलिझम आहे, हा कार्बोहायड्रेट मेटाबॉलिझम आहे, हा फॅट मेटाबॉलिझम आहे. तो आपण पाठ करतो, ते लिहून येतो पेपरमध्ये आणि आपण ग्रॅज्युएट आणि पोस्ट ग्रॅज्युएट होतात तो विसरून जातो आणि आपण मग सगळं फार्मास्युटिकल कंपन्या आणि ह्याच्याबद्दलचा जो अभ्यास आहे तो सगळा इम्प्लिमेंट करून आपली क्लिनिकल प्रॅक्टिस करतो आणि त्याच्याकडे थोडंसं दुर्लक्ष केलं जातं असं मला वाटतं किंवा ते एवढ्या सजगपणे आणि प्रॉमिनंटली पेशंटलाही सांगितलं जात नाही आणि आपण स्वतःही ते करत नाही. तर तसं न करता त्यांनी हे सगळं केल्यामुळं ते कॉन्फिडंटली ह्या सगळ्या विषयावर बोलू शकतात. त्यांनी त्यांचा सूक्ष्म अभ्यास केलेला आहे आणि त्याच्यावर संशोधनात्मक काम केलं आहे. ते बायोकेमिकली आणि क्लिनिकली प्रूव्ह करून दाखवलेले आहे. आपल्या इथले सोलापूरचे बरेच लोक त्यांचे पेशंट आहेत. बहुतेक मी पण पुढच्या महिन्यात त्यांची पेशंट म्हणूनच जाणार आहे. मला चांगलं असं वाटलं की मॅडम गायनेकॉलॉजिस्ट आहेत म्हणजे सरस्वती मॅडम आणि त्यांचं पण त्यांनी PCOSवर काम केलेलं आहे की जी सध्या सगळ्यात मोठी समस्या आहे. कारण तुम्ही जर का OPDत बसलात तर 2-3 पेशंट नंतर एक पेशंट येते की माझे पिरियड्स इरेग्युलर आहेत आणि मला ही समस्या आणि मॅडम मी काय करू. मग अशा वेळेस आपण ती 3-4 गायनेकॉलॉजिस्टकडे जाऊन आधी हॉर्मोनल थेरपी घेऊन आलेली असते. मी 3 महिने ओरालेल घेतलं आहे सायकल रेग्युलर होण्यासाठी, 2 महिने आयुर्वेदिक घेतलं आहे, त्याच्यानंतर विड्रॉलसाठी मी घेतलं आहे आणि आता परत 3 महिने झाले मला पाळी येत नाही आहे. आणि त्या पेशंटचं वय असतं 25. तिला विचारलं तर ती म्हणते माझं शिक्षण चालू आहे, मी 29 वगैरे वर्षानंतर वयानंतर लग्न करेन. आणि मग तिचं लग्न झाल्यावर ती परत येते आपल्याकडे आणि सांगते की अजून मला मूल होण्यासाठी मनाची तयारी नाही झाली, मी अजून 3 वर्ष थांबणार आहे. असे सध्या पेशंट माझ्या ओपीडीत बरेच येतात की दे वॉन्ट प्रेग्नन्सी आफ्टर 30 to 33 इयर्स. मग हे खूप चॅलेंजिंग आहे एका गायनेकॉलॉजिस्टसाठी. आणि आहार आणि जीवनशैलीतील बदल गायनेकॉलॉजिस्टनी स्वतः पण केलेले नसतात, पण ते त्या पेशंटला अगदी छान समजावून सांगतात तू असं असं करायला पाहिजे म्हणून. मग मला काही पेशंट ऐकतात, काही ऐकत नाहीत. तर ही सगळ्यांपुढची एक मोठी समस्या आहे. आणि मला वाटतं की डॉक्टर कणसे सरांकडून आपल्याला त्याच्याबद्दल योग्य असं ऐकायला मिळेल आणि आपण चांगल्या पद्धतीने पेशंट बरे करू शकतात. ते पुण्याहून आले, काल रात्री दमलेले होते, तरी मी आणि चंद्रकांत त्यांना भेटायला गेल्यावर त्यांनी तेवढ्याच उत्साहाने आम्हाला अटेंड केलं आणि काही त्यांचे अनुभव सांगितले. तर मी आता जास्त काही तुमचा वेळ घेत नाही. आपण त्यांना आणि मी यावेळेस शिरोडकर ओरेशन म्हणजे आता अजून एक समानता सांगते डॉक्टर शिरोडकरांबद्दल आणि डॉक्टर कणसेंबद्दल की शिरोडकरांनी नेहमी स्त्री आरोग्यावर काम केलेलं आहे आणि संशोधनात्मक काम करून त्यांनी सर्वायकल स्टिच हुडकून काढला आणि मातृत्व स्त्रियांना मिळालं आणि त्यांचे प्रॉब्लेम कमी झाले. ते कायम संशोधन करत राहिले आणि ते त्यांनी त्यांच्या क्लिनिकल प्रॅक्टिसमध्ये आणलं. तसंच डॉक्टर कणसे हे फिजिशियन असले तरी त्यांनी स्त्रियांच्या आरोग्याबद्दल विचार केला आहे आणि पॉलिसिस्टिक ओव्हॅरियन सिंड्रोमवर त्यांचं स्वतःचं पण काम आहे आणि मॅडमचं पण काम आहे. आणि मॅडम गायनेकॉलॉजिस्ट आहेत, बेटर हाफ आहेत, त्यांचा प्रभाव जास्त आहे सरांवर आणि ते दोघं मिळून सगळीकडे संशोधनात्मक कामाची व्याख्यानं देतात आणि त्याबद्दल समाजात बदल करू इच्छितात. ओव्हर टू यू सर.
Thank you, Dr. Ghate, Madam. I now request upcoming President, Dr. Sujata Kulkarni, Madam, to present the life sketch of late Dr. V.N. Shirodkar.
Respected senior members of our society, our today's chief guest, Dr. Chandrakant Kandse sir, dignitaries on the dais, and my dear friends. A very good morning one and all, and it is my proud privilege to present before you the life sketch of Padma Bhushan, late Dr. Vitthal Nagesh Shirodkar, an era of 1899 to 1971. The great legend in the history of obstetrics and gynecology. Doctors are indeed born. This is amply true about Dr. V.N. Shirodkar. 1899 was the invintage year for biomedical science, especially for innovative surgeries of the female genital tract. For in that year was born Vithalrao Nagesh Shirodkar in Shiroda, a hamlet near Fonda in Goa. He grew up in Goa and later educated in Hubli. He did his paramedical studies in Pune and Deccan College. Sir did his medical training from Grand Medical College in Mumbai, MBBS in 1923, MD in 1927, and FRCS from England in 1931. He served as an honorary obstetrician and gynecologist at JJ Group of Hospitals in 1935 and Varia Maternity Hospital. An era of 1955 to 60, era of distinguished work. He was a peerless surgeon, an artist, and his contribution speaks of his active and imaginative mind. Dr. V.N. Shirodkar's curriculum vitae reads like an ever-climbing graph. Such are his achievements. This great son of India has most certainly placed our country on the medical map of the world. In 1955, Dr. V.N. Shirodkar described the cervical cerclage operation, a surgery which has stood the greatest test of all time. This operation is now popularly called as Shirodkar cervical operation. He innovated special instruments for the repair of incompetent cervix. The instruments were a retractor, a sponge-holding forceps, a fascitome, Shirodkar needle right and left, and on non-slip speculum. He realized that catgut was not enough and used fascia lata from thigh as a suture material at the level of internal os. He was astute enough to realize that his operation was not a remedy for all habitual abortions. He clearly laid down conditions where operation was most likely to be successful and where it would fail. Operation of cervical cerclage was a masterpiece. He described his operation at International Conference in Paris in 1951 and Naples in 1956. With all due respects to the old masters, I did not reconcile myself to some of the operative procedures which fell far short of the ideas. Ideas came to my mind for improving the time-honored method. His other contributions in gynecology, he invented operation for absent vagina. Sir used colon for reconstruction of vagina. He described 2 operations for uterine prolapse. The vaginal operation consists of using uterosacral ligament and bringing them in front of cervix. And second was the Shirodkar sling operation. The Shirodkar technique for contraceptive vaginal hood, which he described in 1971, was also very famous. Shirodkar technique for uterotubal implants. Dr. Shirodkar was dealing with lot of cases of infertility due to tubal block after illegal abortions. So treatment of corneal block was a challenging problem. In 1957, he presented a study of 100 cases. He devised implantations by using special reamer. He used tantalum wires, polythene tubes to keep the fallopian tube open. His contribution to family planning. He was a member of Shantilal Shah Committee on Abortions. He founded, along with G.M. Phadke, Family Planning Association of India. According to Dr. Shirodkar, tubectomy should be performed at the widest portion, and you have to separate 2 ends to prevent unwanted re-establishment of continuity. He was a hardcore surgeon. His day would start at 5 a.m. or maybe earlier. He worked for almost 14 to 16 hours a day. He was a distinguished surgeon, and his precision and gentleness in handling tissue was delightful to watch. His instruments were not mere inert objects, but they were like a person's to him. He rarely operated without an audience. Dr. Shirodkar, the great teacher. He captivated his students, and many generations of students remember him with affection and gratitude. We are proud to say that his student, late Dr. Vitthal Balkrishna Kulkarni, was the founder president of our society. We still remember the real-time memories told by him about his guru, Dr. Shirodkar. He had numerous publications to his credits. In 1960, he published a monogram on the contribution in gynecology, which was dedicated to Shri Pandit Jawaharlal Nehru. In 1963 and 70, he contributed a chapter on incompetent cervix, a chapter in advancement in obstetrics and gynecology by Marcus and Marcus. He has put his own diagrams in his publications, which depicts of his artistic and meticulous approach. It includes his original drawings on various techniques, instruments, and operation. In 1966, he, along with Dr. Shrikhande, did first exchange transfusion of RH isoimmunization. And we are very happy to say that this was done on Dr. Vandana Honap, who was daughter of Dr. V.B. Kulkarni at the time in Mumbai. Honors bestowed on him. He was honored with every society, right from Indian Foxy Society to Honorary Fellow of the Royal College of Obstetrician and Gynecology of England, Honorary Member of the French Society of Obstetrics and Gynecology, Honorary Member of the Society of Obstetrics and Gynecology of Brazil, Fellow of American College of Surgeons. President of India awarded him Padma Bhushan in 1960 and Padma Vibhushan in 1970. His unique gifted personality. He was very academic, artist, and a progressive thinker. He was a man of a great charm and humor too. He was a sports person, loved playing tennis and golf. His paintings and drawings provided him relaxation. He has learned to play violin. He was multilingual, can read in Russia too. He was warm and human and was respected and loved by everybody who came in his contact, maybe rich or poor. This was the famous Haji Ali Dargah which he had drawn, which Dr. Shirodkar sir had drawn. His devotion to private practice was most distinguishable when he performed Indira Gandhi's delivery when Rajiv was born. Beside being a busy practitioner, Professor V. N. Shirodkar published many books and papers and took a keen interest in social medicine. Dr. Shirodkar, he started Dr. Shirodkar Special School for Mentally Retarded People. His family, his wife was the CEO of the hospital. His son Manohar V. N. Shrikande spent his career studying Ross sarcoma virus at the John Hopkins School of Public Health and later returned back to India. He lives among us and his contributions toward mankind. His work has been a great source of inspiration to all of us. He can be best described as the scientist, the healer, the man. We, the Solapur OBGY Society, pays laurels to him. Thank you.
Thank you, Sujata Madam. As a gesture of remembrance and gratitude, I now request our guest speaker, Dr. Kanse sir, to give floral tribute to late Dr. V. N. Shirodkar. Please. We are about to commence our event by lighting the lamp of knowledge and wisdom. It is our honor to invite respected Dr. Kanse sir, Dr. Neeta Ghate madam, Dr. Lalita, Dr. Chandrakant on stage for lamp lighting. Witnessing the lamp being lit, may it inspire us all. The flame's upward movement, defying gravity, stands as a symbol of our quest for knowledge, upliftment, and a resolve to rise above all challenges. A heartfelt thanks to our esteemed guest, Dr. Kanse sir, for leading this auspicious beginning. With his luminous start, we now proceed with our schedule. I request all dignitaries to take their seats in audience for our oration. I would like to invite chairpersons Dr. Bahubali Doshi sir and Dr. Rajiv Dabde sir. I request President Dr. Ghate madam to welcome our chairpersons.
Hello. For the first time in the history of Solapur OBGY Society and the Shirodkar Oration program, somebody else than a gynecologist or related to gynecology is being invited. There is a saying, the taste of soup is in eating it. So for next 90 minutes, whatever has been said about Dr. Kanse, you will agree to that saying. Set झाला laptop set झाला. So I request Dr. Kanse to enlighten us on that catchy heading which he has given for the today's topic, solving the metabolic maze of PCOD.
It will be useful, not for the day, but for the practice that you are going to attend ahead, right? म्हणून मी नेहमी माझ्या लेक्चरची सुरुवात अशी करतो, तुमच्या शपथ सांगेल ते सत्य असेल आणि सांगितलेले सर्व शास्त्रीय आणि उपयुक्त देखील असेल. Basically, when you start thinking and talking about PCOS, we have to come out of that knowledge or information that, or the wisdom or experience that you are having for last maybe decades or whatsoever it is. You must give up that concept, your understanding, keep it at the back, and try to see through the recent knowledge and information, the research that is coming across the world. Right? Earlier, when the Steen Leventhal, basically 2000, I think 1906, when it came, it was, you used to see the sporadic cases, maybe one patient, two patients, something like that, and there used to be case reports. By the time Bahubali sir passed his MD, that time also it was not that rare, that common. We used to see one patient a week or maybe in a month, and then we used to discuss it as an uncommon, rare entity. And we leave it to the gynecologist and something like that. I would not have been interested in PCOS had it been a case of putting on 1 or 2 kg or 5 kg and a few missed periods. When I started working with the diabetes, that was my own problem, then I realized it is not only the PCOS, it is not what is being taught to us, what we have studied, what we have read. By the way, I was also topper in the gynecology also, MBBS. So then what happened, the patient used to come, when I started working on these metabolic things, the patient used to come to me for obesity, diabetes at a young age. So 25, 30, 35 is the type 2 diabetes. And then when I started with my schedule, then I realized that it's not only the diabetes that is getting reversed, that PCOS also started responding. Many ladies started saying, no, I had a problem, this thing, now I am pregnant. I had a missed period, now they are regular. Then I went further. I said, then I enlarged my history taking sheet. And then how did it started? When did you started having the problem? How was your childhood? What did you eat? And all those things. And then I said, is something seriously wrong? Then I discussed it with my wife. We need to take that issue into consideration and we must start working on it. Then we had a plan. Then we read extensively. We spent 2 complete years in studying the PCOS. Is it the same of diabetes or something different? And as of today, what I know, what I understand, it is nothing but a diabetes early signature or diabetes early signs and symptoms. Then I used to get lot many VIP cases for gestational diabetes, for management and control. Then I spread the same sheet further, and then what I realized, it's not gestational diabetes alone what we are dealing, it is a delayed diagnosis of PCOS at this age, and it starts maybe 10 or 15 years of age, and that's what we are dealing. And then, obviously I get many patients at the 40s and 50s and 60s. Then if you increase the history spreadsheet, then you will come to know, नाही मला gestational diabetes होता पण 4-5 वर्ष बरं होतं. नंतर हा सुरू झाला. And then I realized what is missing. It is a mistake from our side. Because we failed to understand the pathophysiology of PCOS, gestational diabetes, we thought these are 2 separate entities. And then diabetes, we thought it is a separate entity. It is not separate. It is one and same continuation. Because then we realize that puberty and pregnancy, these are the 2 normal physiological states of insulin resistance. Right? Puberty, it is somewhat lighter, but during pregnancy, it is especially in the 3rd trimester where we get a gestational diabetes. Right? And there the patient dips into that so-called diabetes, and I am happy to tell you, till date, not less than 1,000 patients gestational diabetes, and nobody required a postnatal care, not a single child. Right? All VIPs attend to me. I had a detailed record of everything, W sir must have seen. Right? Not a single patient attends to NICU care, not a single child. Right? So we must change our thinking process. That's what Einstein famously said, we cannot solve our problems with the same thinking we used when we created them. We considered it a different entity. We did not focus on the cause of the problem. That is the main issue. Then I went back to the Guyton. Then I went back to the Harper. That's what I told sir. When I have to reverse my diabetes, 2013, I bought a brand new edition of Guyton and Harper. I read all the metabolisms, endocrine topics, and then I realized that something is seriously missing. Then I am basically a Harrison guy. So I read Harrison maybe many times, and especially diabetes maybe 10 times. Then I realized there's a huge difference between what the Guyton is telling and the Cecil or Harrison is telling. Huge disconnect between the basic sciences and the applied sciences. And that bridge gap has to be, you must bring it together, and that's what can be called as a treatment. Then I read William Osler, 1905. He's the father of modern medicine, considered as. And then one line caught me a very big attention. You must find out the cause and treat the cause. Our primary responsibility to ensure that the patient gets minimum medicine for a minimum duration of period. And as many of my patients from Solapur has also experienced, that 70% of my patients do not get a single tablet. If you study the patient properly, if you are proper in history taking, you don't need a drug for this kind of disorders. I'm not saying infection and all those things, but so-called metabolic disorders or the lifestyle disorders do not need a tablet. And then what I discussed with Madam Ghati yesterday night, that it is absolutely wrong to prescribe insulin to a patient of type 2 diabetes. That's what and you can go for a case study in near future if she attends to me, right? Because that's what I talked to her. Diabetes is a disease of too much insulin, right? What is rational in giving more insulin? What is rational in prescribing a drug which increases insulin? There is no rational. Because our outcome criteria are deficient or you can say not correct. We focus on controlling the sugar. That should be one of the criteria, should not be the only criteria. We must focus on the cause of hyperglycemia. What made the sugar to go up? You never ask that question. Ki, sir, sakar vadli. Kashane vadli? You must find out the cause and treat the cause. It may be infection, it may be stress, it may be sleep deprivation, it may be lack of exercise, it may be the food. That is the commonest. Right? So we fail to understand, come to a conclusion for the cause issue. And we are just treating the symptoms. That's what I read, written here. We need to change our thinking and try to find out the cause. And we must focus on treating the cause. All the experienced and the learned people sitting in front of me, are you treating a cause or symptom? Anovulation, give ovulation inducing drug. Irregular menses, give OCs, right? Hair problem, give cosmetic management. Weight loss, weight loss drugs. Isn't it? That's what we have been doing. Is it a treatment? Or is it a symptomatic treatment? Or I call it the palliative treatment. Right? We are far away from finding out the cause, and that's why treating the cause goes always wrong. Right? We're trying to treat only the symptoms without knowing the cause. For this type of cases, we must try and find out the cause. Treat the cause. Cause may be different with everybody. No harm done. But what are the attempts we are making? So the obesity, is it a symptom or a cause? Symptom. Hair growth, is it a symptom or a cause? Again a symptom. What is the rational in treating? Acanthosis, we are sending patient to, the skin specialist or cosmetologist, right? And this you all know well. There are the three features of PCOS, hyperandrogenism, anovulation, and polycystic ovaries. You know it better than me. I need not spend my time and your time also, right? And what are the challenges of diagnosis? There is no single criteria, right? No single diagnosis test which can say this is the patient of PCOS, right? And on top of it, there are a variety of other causes which lead to similar symptoms. So that is the biggest challenge. You have to find out from this, let's say obesity, a variety of causes, hirsutism, variety of causes, anovulation, variety of causes. It's not only PCOS. You can have variety of causes contributing to the same symptoms. And why it is important to learn and think and discuss and invite me here? Basically, you must know the important facts. 1905 to let's say 120 years now, what is the magnitude of the problem of PCOS? Maybe 100, 200 times. And we still think that it is idiopathic? Who is the idiot? My simple question, who is the idiot in the show? It is definitely we. We the learned people. We the qualified practitioners. We are the idiot. And we have been taken away from the core science or basic sciences to prescribe the drug. That I will talking further. The incidence and prevalence of is increasing. It's not about India. It's not about you and me. It is increasing all over the world. It has nothing to do with the genetics. Genetics that I will be discussing shortly. Presently, we are focusing on the symptomatic management. That is the worst thing that we can do. And we must understand that PCOS is a metabolic disorder. It is something wrong with the metabolism, and that trigger factor we must try and find out, right? And the cause, underlying cause of all these manifestations is the insulin resistance, right? I will be repeating the same sentence again and again in the lecture. There is no drug on earth which can reverse or reduce insulin resistance. Thankfully, there is no drug. Thankfully, there is no drug, and more importantly, you don't need it. That's why I said you don't need a drug and there is no drug, right? And we must treat the insulin resistance, right? Then we go to the run over the basic endocrinology. That's what how every symptoms you can be traced back to the root cause, that is hyperinsulinism, into bracket, insulin resistance. You get hyperinsulinism, the biggest trigger factor for release of insulin is your food. Obviously, there are many other factors, but there is a factor which is most important, strongest one. If you go to basic endocrinology from the Guyton, it is clearly written, carbohydrate stimulates insulin release to the most extent. It is written in Guyton. We forgot that. Then the insulin response to the protein is 50% of the carbohydrate. And fat elicit no response or very little response. That is there in the Guyton. We forgot. And then we'll come to know, it leads to basically why there is obesity. I have classified the symptoms into three different categories: hyperandrogenism, hyperinsulinism, and anovulation. I will take you through the pathophysiology so that you can understand the basic underlying cause of it. Then it leads to the basic function of the insulin is to decrease lipolysis and put in more fat into it. Basic function. It's an energy manager in the body. So it prevents lipolysis and it adds to the lipogenesis. So you get obese. Then we are treating everything else but the insulin, right? And then obviously because of there is insulin, more and frequent insulin, that leads to insulin resistance, that leads to leptin resistance. In spite of having so many calories stored in the body, you are hungry. Because the basic function of leptin is to give a sense of satiety that will control your hunger. Right? So you become hungry and then there is a craving element. So if you are hungry and if you don't get food to eat, you eat whatever is available. Right? And then hyperinsulinism leads to increased action of the epidermal cells. That leads to acanthosis, skin tags, obviously. And then what I discussed with the madam and Chandrakant sir also yesterday night, fatty liver, we pass it as a normal. Absolutely insane. We must try and find out the cause and treat the fatty liver at its earliest. Because that is where it starts. You are waiting for the end point. You must treat. Fatty liver is not a physiological entity. It is a pathological entity. Grade 2 fatty liver, 27% of the liver mass is fat. And you consider it as a normal? When I passed my MD, or maybe senior those sitting in front of me, when did you pass your MD? Did you ever see a non-alcoholic fatty liver? No. We used to say very rarely, the fatty liver or the liver damage, unless said otherwise, was attributed to alcoholism. Second was hepatitis B and C and many other things, but that's a rare. The common is unless said otherwise. So there used to be common history question, की दारू पितो की नाही हे विचारायचंच नाही, किती पितो आणि किती वेळा पितो, म्हणजे पितो की नाही हे विचारायचं. फॅटी तुम्हाला लिव्हरचा प्रॉब्लेम दिसला की तो पितो की नाही हे तुम्ही अज्युम करायचं. जस्ट लाईक अ गनोरिया. इफ यू सी अ पेशंट ऑफ गनोरिया, डोंट आस्क फॉर द हिस्ट्री ऑफ एक्सपोजर, assume it, right? That's how my professor used to tell us. That is assumed, right? Now, what is common? Alcoholic fatty liver or a non-alcoholic fatty liver? It's a non-alcoholic fatty liver. The biggest indication or the highest number of patients attending to the liver transplant, is it from the alcoholic group or non-alcoholic group? It is from the non-alcoholic group. We have gone to that extent. So we wait for the patient to travel that much distance so as to reach a point of demanding a liver transplant. Isn't it? We would have handled the problem when type 1 and grade 1 and grade 2 fatty liver. It is easy. Right? So this is how the demand for liver transplant is increasing. As it grows, it simply indicates our negligence or ignorance of treating the patient at the baseline level. Baseline level, no treatment required, except the no drug required. You need to understand and treat fatty liver. It is extremely easy. The easiest thing that you can do is advise, handle and manage the patient of fatty liver. Right, basic endocrinology, again, anovulation. You know that there is a hypothalamic pituitary axis and the LH is pulsatility is lost and there is lack of LH surge and there is estrogen, the aromatase inhibition actions. So I will not go into this thing. Basically, we are talking about all these things. Basically, you know it better than me. isn't it? I know it theoretically, though I have practiced it, right? So I will just skip over this. And now this comes. The way we are handling the PCOS as on date, right? If there is a insulin resistance, we talk of insulin sensitizer. What is the potency of the metformin to improve the insulin resistance or inositol for that matter? There was a research proposal by one of the biggest organizations. I will not name them because yesterday I discussed with your president that the comparative study of effectiveness of metformin against inositol in a patient with PCOS. Then I wrote to that this thing, sir, you please add a third arm where you don't need a metformin or inositol and compare it with the lifestyle modification. I have written a letter also. The agency did not respond. Absolutely no response. So we are interested in studying a drug. We are looking for a solution where there is, where it is not lying there. I refuse to accept this thing proposal, 2 years follow-up study, because madam's trial is registered with the CTRI, Clinical Trial Registry of India, right? And for the sake of your information, I proudly declare that she has been invited as a keynote speaker for the upcoming Bangkok conference, right? Europe and Asia together, just because of the synopsis she had sent, and she has been invited. So I wrote to the research organization in India, this is not what the research is. You compare with the basic thing, and then you say that whether metformin is required or is full, or the lifestyle. And till date, I have got no answer. Right? I said, I will do it myself. I don't need your money also. You supervise, see that it is authentic, see that it is scientific, and let me know my difficulties or deficiencies or irregularities. Last 3 months, I have been waiting for the reply. Okay? Then we take up inositol and this thing and that thing, the berberine and many other things. Then for menstrual irregularity, we go for OCs, right? Then ovulation drug, the weight loss drug. There was when I asked, the topic came to me, then I asked, what are your difficulties? Please let me know, so that I can prepare the lecture accordingly, so that it will address to the issue that you are looking for. You have sent me all the queries, and they are all drug related. Am I correct? And you have forwarded some queries, and they are all drug related. We are so much biased, prejudiced, to look into the answer of every symptom in the form of medicine only. So we are looking for a pill for every ill, isn't it? There is no solution, sir, in the pharmaceutical market. We don't need it, and it is not there, right? And then, yes? Okay. So the weight loss drug are listed. What is the rationale? I have yet to use a single drug for weight loss. Yet to use. I have not used a single drug in last 11 years for weight loss. And I have not witnessed a failure also. I was eagerly waiting for one patient, 170 kg, along with a wife who was supposed to attend today. But somehow they are not there. I would have presented you the case along with the schedule. You would have implemented it here as a case study. You can do it, isn't it? You can all do it here easily. Right? I was waiting. Somebody told me that they are definitely going to come. Somehow they are not there in the crowd. Okay, now I'm done. Then somebody asked me about the GLP-1 agonist. What is it? Why do you need it? But they are using it. They are absolutely irrational. Right? Then we go for cosmetic management. I don't recommend anything. Then obviously anti-androgens, and then emotional disturbances. That is a big chunk. Many of the women, for the reasons associated, do go into anxiety, or maybe in some cases in depression. And then weight loss remedies. That honey, that worries me the most. However on earth honey can reduce weight? Anybody can answer. Cannot be. Isn't it? The false narrative has been perpetuated under the name of Ayurveda. Isn't it? How on earth honey can reduce the weight? And I think it is the most commonest practice modality.
Only if you call your wife as well.
That's hilarious. Thanks for the nice answer, so that I can go on speaking about it in my next lecture. Right? And then, see, it's not about, they are doing it as a bona fide advice. Doctor's advice. Somebody says, मेथीचा अर्क, then काढा, कारल्याचा रस, भोपळ्याचा रस, and then there is even नवस, गंडादोरे, देवी, तेवढ्यानी काय होतं आहे, असं कुठं असतं काय, मोठ्यांचं ऐकायचं असतं, आमच्या शेजारच्यांनी केलं आहे. These are all the answers you must be getting. Why we allow the society to go to that level? Isn't it? It is our failure. We did not, or we failed to understand it properly, and that's why the society is following alternative medicine. If you take a history properly, you will find 8 out of 10 patients attend to some alternative medicine. It is our society, our failure, sir. Why a person who is attending to you would like to go for some Gandadora, Devi Navas, and Bai Boa, isn't it? There are people who are coming. If you open the YouTube or anything, you will find hundreds and hundreds of alternative solutions. Anything but scientific. Anything but scientific. Hundreds of people. लोक थांबतच नाहीत. इतक्या प्रकारचे, म्हणजे मी मोजून थकलो. मागे मी एकदा टोटल केली की हाऊ मेनी टाइप्स ऑफ अनसायंटिफिक ॲडवाइसेस बीइंग गिवन टू द डायबिटिक पेशंट. 220. And then I stopped counting. And that's how it goes. Right? Why I am speaking here? Basically, this is very important. What is your role in the system? What is the importance of being a gynecologist? How can do it? Believe me, you have the best and the longest opportunity to make an impact. Physician, we come at the last end of the show. But you are there from the beginning. That I will try and explain you. Right? You have the best and longest opportunity to make an impact. Not only in patients. I am not talking about the patients, but family and society as a whole. Imagine an event of childbirth. This side also. Isn't it? They attend to you 9 months. I am not sure whether all my patients attend to me for 3 months. No? एकदाच येतात, काहीतरी सांगते the doctor, हे आपल्याला नाही जमणार. Isn't it? This is common repercussion that I get. But yours is a different situation. You attend the child, the mother, both the sides, maternal and this thing, and you have got the longest opportunity. You must dive into the problem and see that the problem is solved. You will benefit, the society will be more than benefited. Right? And that's why I quote Hippocrates, that healing is a matter of time for the patient. But it is sometimes a matter of opportunities for the physicians. And you have the longest. This is how the patients of PCOS or any, for that matter, metabolic disorders evolve throughout the life. Right? Firstly, they attend to the pre-pregnancy, then maybe before the birth, then 15, 20 years and on. We start with the amber line or the red line. Physicians enter there. By the time, and the last line is very important. If you act in a preconception level, it is almost 100% sure that you will get a success. And there are enormous number of studies across the world, nicely done, without any confounders, available, which states that if you act in a pre-pregnancy level, then the success is 100%. It is most effective. As the age advances from 0 to till it attends to my clinic, the chances of success are go less and less and less. And you deal with the first 40 years and maybe beyond that. Right? And that's why I made a star line in between here. And then the type 2 diabetes, cardiovascular disease, and this cancer and Alzheimer's. This is my domain, essentially. Where the chances of success are very less. Very less. Difficult. By the time the habits and everything have done the worst that can happen to the person. You are at a very early stage. You must take up the charge of the system. And you can do it. It is very easy. Right? Have you understood that this is where you must start acting? The day the patient, you are attending the patient, maybe first trimester, second month maybe. Obviously not first month, but the second month, you insist on the proper health of the mother and father. Do not forget the father. If at all you want a child to be healthy, to live healthy for life, you must intervene both the parents at the beginning. That's what I do. Right? So you intervene at the stage and protect the child from getting a PCOD. Right? Since the pregnancy is there, you all say that, ho gaya. Now we have to take over the mother and father, mother and the child in a different sense. No, it is far much more than that. We can do it better. Right? So the pre-pregnancy or preconception, that is the area where you should start working, and the 15, 20, 25, 30 or 40 years, they attend to you for a variety of reasons. Please insist that they follow a proper health protocol. Right? That's what I said. I was invited for a very big conference. I said, just like a national anthem, it's a single national anthem all across India. One anthem we speak, Jana Gana Mana, isn't it? There is no second. We all doctors must come together and sing a common song. Even if it is a patient of headache, you must advise him properly. If it is a patient of intestinal something, what you are doing, you must advise the health. Every now and then when you come in contact with the patient, insist on health. Unfortunately, what has happened, the present medical education or the system which we all educated have made us the disease care specialist. We need to go away, or at least must join the team of health care specialists. We know nothing about this thing, health. That I will discuss further. Right, that's what I was talking about, the preconception. Right, we think genetics is only related to genome, DNA, isn't it? Or RNA, for that matter. Right? What about the nucleus that contains, or the ovary, the ovum and the sperm, they unite together, has a fertilized egg. That is the DNA inside. What else is there? Epigenome, the area surrounding, or the cytoplasm you can say in a simple words. Right? How the DNA is going to behave is determined by the cytoplasm surrounding, that is called as epigenome. And that epigenome is highly influenced by the health of the mother and father, especially the mother. That's why I have given 2 arms for the mother and 1 arm for the father. Because once fertilization, the paternal arm is taken away. Right? So the mother, health of the mother is paramount. Right? And what are the obstacles that you need to correct at that time? The plan of action. How are you going to assess the problem that she is likely to have? Right? And what do you start with? Dohale. Kai dohale deto? What is the content and what is the effect? All sugar and sugar and sugar. खाऊ दे तिला. खायलाच पाहिजे. आईने आणलं, मावशीने आणलं, आजीने आणलं, सासूने आणलं, नवऱ्याने आणलं, मैत्रिणीने आणलं. And what is the effect on the so-called womb, the fertilized zygote, this thing? It increases the sugar in the mother, it increases the insulin in the mother, so that fertilized ovum get exposed to the high sugar and high insulin. Even in non-PCOS cases, I am telling you. Even in non-PCOS cases. And what is the impact? That the cells start behaving as if there is hyperinsulinemia constantly. What is the age of onset, usual age of onset at which you expect the patient to have a type 2 diabetes? Any idea? When I passed, it used to be 60 plus. 1986, it used to be 60 plus. Then, maybe 10 years down the line, I started saying the patient has the 40s and 50s. Still more in the line today. What do you expect? 25, 30. Why? We failed to ask this question, why this is happening? Now I diagnose patients of type 2 diabetes at this was 6 and 8 and 10 and 12. The first patient I distinctly remember, when I diagnosed the patient of 12 years old age with a type 2 diagnosis, I literally cried in front of the parents and the patient. I said, what is what we are doing here? If you cannot protect the child being type 2 diabetes, because this question was asked to me in one of the conferences, that's what I'm saying, the pre-diabetes stage, before the pre-diabetes, before HbA1c pre-5.7, it takes around 10 to 15 years. All the research says it's 10 to 15 years that you follow this worst type of lifestyle, and then maybe 15 years down the line, you get a patient full-blown type 2 diabetes. The child is only 12 years old. Where are those 15 years gone? And maybe 3 months, you are diagnosed. Child is only 8 years old. What are we heading for? What are we heading for? Child is 8 years old. I took a 2-page history of the mother and father separately from their birth, whatever they can remember. And there lies the answer. This is the answer. Right? Because the mother was tempered, pampering in a very such a bad manner that she delivered a child, a male child, who became diabetic at the 6 and 8. Is it what we are looking for? Is this what we want? And the history matches to this assumption. Right? There is Michael Hertz is a scientist. His wife looks into the, what you call it as genetics and other things, or maybe nutritional psychiatry. That's what my recent focus of this thing. My son is a psychiatrist, and we are doing much better work, not only in diabetes, but in nutritional psychiatry. Totally neglected issue. As it is, psychiatry is neglected, so nutritional psychiatry wo to hawa mein hai. So there lies the answer, because the child started getting exposed to the high level of sugar and insulin while in the womb. What does it mean? The incubation, so-called, you can understand it better, that the so-called incubation period of the diabetes is half now. That's why you get many children with diabetes at the age of 6 and 8. We don't look for it, we do not think of it, but that's the reality, right? So that's how the mother should be advised, even when she is pregnant, about the nutritional or proper lifestyle advice. Right? So what is the cause of insulin resistance? That is occupying all our aspect. Sir, I will share the slides with the president, and you can distribute. I don't reserve any of my knowledge in my custody. Nothing. And it will be made available to everybody. The PPT will be made available freely to anybody. You can share. Right? And after seeing those, if at all you have any questions, I am free to answer. Please do not hesitate at all to ask me a question and prove me stupid. I have no objection. I will be happy. Right? So you try and understand. Right? What is the cause of resistance, sir? Leave aside the insulin, but what is the cause of any resistance for that matter? Let's say, what is the cause of drug resistance? Drug only, overuse. The drug, when it is overused for a prolonged period of time, leads to resistance. What is the cause of viral resistance? Virus itself. Then what could be the cause of insulin resistance? Insulin itself. Why are you looking for some other cause? The answer lies there. We must understand that insulin resistance is because of insulin itself. And then how we become insulin resistant? High level of insulin and continuous level of insulin. Isn't it? If you go to the basic digestive physiology, you will come to know, if you eat something, it goes up the nutritional levels in the, let's say blood sugar level, and comes back maybe in the 3 to 4 hours. Isn't it? That's why we do the, postprandial blood sugar after 2 hours. That peaks around 2 hours and comes down in 2 hours. It is followed by the insulin, same curve. 4 hours, the insulin comes back to normal. Then if we eat, say the breakfast, let's say around 8 o'clock, then we have a lunch at around 2 o'clock, 6-hour difference. And what is being told? Can you tell me the advice of American Diabetic Association, American Heart Association, ICMR, or Diabetes Society? What is the advice being given? 3 major meals and 3 snacks. By the time it reaches the baseline, you again start stimulating the insulin release. How the insulin will ever come to baseline? We'll never know. So you need a patient to have a period of fed stage and a fasting stage. And that fasting stage or baseline level, then it goes down also, basic level. That ensures that there will not be a resistance. There has to be a period of absence of that particular stimulus. That is short, in short. We are eating throughout the day. You can call it a grazing also. If it is animal, we call it a grazing. And we have been advised to do so by the expert. That's the recommendation. 3 large meals with 60 grams of carbohydrate per meal and 3 small meals. So we eat at least 6 meals a day. आणि मग हे आले खा, ते आले खा, खायची वेळ झाली खा, वास येतो खा. How on earth the insulin will touch a baseline? It will never reach the baseline. If that continues to happen over a period of time, the system stops responding. That we label it as insulin resistance. Obviously, there are certain cells in the body which are not resistant to insulin, like ovary. And that's what you are dealing with. You don't get ovary resistant to insulin. What we are talking insulin resistance is a systemic part of the insulin resistance, not ovarian part of the insulin resistance. Ovary remains sensitive. Gonads remain sensitive. Adrenal cortex remains sensitive. So you don't call it as the insulin resistance of the ovary, no. It continuously acts on the thicker cell. That's very important. But all other cells in the body do have insulin resistance because of this. So the higher level of insulin is a food. Food is the basic outside trigger that stimulates insulin release. And consistent high levels is frequent eating. Right? And then obviously there are receptor actions. The fructose is very funny. That I will discuss in the next slide. Fructose is very funny. We all consider it as the healthy, isn't it? Eat plenty of fruits. I will tell you the science behind it. And then there are other this thing. Patient-wise the weightage differs. The insulin antagonist, inflammation. Insulin is not allowed to act. Like the stress, not allowed to act. Drugs, right? Obviously the steroid is first in the list and there are many other. And the pollution. It is documented scientifically. Pollution enhances the insulin resistance, decreases the sensitivity of the receptors in the body. The water bottles in front of you. Everybody is having water bottle. Is it healthy? Why are you taking it? Isn't it? The problem lies in front of you. Microplastics. Isn't it? We must act scientifically. If I am saying anything wrong, please let me know. It is known to contain microplastic, and if you continue to drink it every day, they get accumulated in your body. There is no exit for microplastic from the body. No exit. Stop drinking at least. Ask for the glass. Reusable. It is easy and cheaper. But we are fascinated with this thing, isn't it? We stop thinking and questioning. That is the big problem. I don't have a watch basically. So please remind me as 1 hour and 15 minutes. Isn't it?
The slideshow is a watch for till that last slide.
No, because I usually give 3-hour lectures. Okay, when you are bored, when there is a time to leave, please let me know, I will sum it up. Right? What we know and understand as an insulin resistance, what the book says? Anybody can recollect? Your gynec or medicine books? We do not know. Some idiopathic, some environmental, some genetics. Isn't it? That's what is written. Even the recent edition, I have read it carefully. Doesn't mention food as the most important factor. Frequent feeding as the most important factor. Doesn't mention the cause. So what we have been trained, read, studied, passed, graduated and post-graduated, I think it is unscientific. You can go through any new research and it will acknowledge or endorse what I am telling you. Right? You can refer to Dr. Timothy Noakes. He has written a very 800 pages textbook on insulin resistance only, on all the diseases that are secondary to insulin resistance. Right? If you do want, I will send you the PDF. You get it printed. Otherwise, the books was 12,000 rupees. Right? Being an Indian, I know jugaad. Right? And what we consider or focus as a solution, that is exemplified by the question that you asked me. Everywhere you ask for the drug. Whether to use, when not to use. That's what I talked to Madam yesterday night. That there was an international conference, online conference, that were the Corona days, and I was also part of it, not a central part of it. And the title of the seminar or the conference was Newer Insulin and its Ways. Recent advances or evidence-based or this thing and that thing, how to use insulin effectively. And then at the end of the conference, they asked me, sir, what is your opinion? How do you think about the conference? Which insulin is good and what would be the doses? I said, where is the science and where is the evidence? Tell me, and what is new about it? If at all there is a recent evidence or a new technique, it should address to when not to use insulin, how not to use insulin, how to reduce insulin. कोई 70-30 बनाता है मिक्सड इंसुलिन, कोई 50-50 बनाता है, कोई 25-75 बनाता है. एखाद्या भाजीमध्ये मीठ टाकलं, एखाद्याने जास्त टाकलं, एखाद्याने कमी झालं, याच्यापेक्षा माझ्या मते त्याला भेटेच काही नाही. You must tell the patient, tell the delegates, how not to use it. That would be recent. That will be better. Isn't it? Then on, I am not invited. Okay? And what are we supposed to treat? Insulin resistance. And that's what I said earlier. There is no drug for it. And the best part is, we don't need it either. We can very well treat insulin resistance without use of a single tablet. It is very easy, scientific, effective, and can be managed with the long term. I will tell you the difficulties and challenges of practicing the way it should be. Then the only scientific treatment that involves, the way to treat insulin resistance involves food or nutrition, sleep, obviously including stress, activity or exercise, and sunlight. Right? And obviously the pollution and the avoidance of the drug. But you can't sell it, you can't buy it. Isn't it? There is no GST on sunlight. We all avoid it. If there is around 60-70 people sitting in front of me, you test your vitamin D. I am 100% sure every one of you sitting in front of me will be vitamin D deficient. Isn't it? How about your immunity? What decides your immunity? How about your sleep? What decides your sleep? What decides your circadian rhythm? Isn't it? What decides your bone strength? Is it taking calcium sufficient? Do you have a diet that is calcium deficient? Or do you are deficient in sunlight? What is the answer? Deficient in sunlight, and to what extent? I have yet to find a person who has got normal vitamin D level, except me and my wife. My vitamin D level is already around 60, 70, 80 without a supplement, because I am a farmer. I spend a lot of time in the farm. Whether taking vitamin D is a sufficient alternative for sunlight? No. If it is sunlight is 100%, what weightage will you give to vitamin D? Not even 10%. Not even 10%. And what else it is? What else it is? If it is not only the vitamin D, because you can treat biochemistry. I call it a titration, I don't call it a treatment. But that's what I'm saying. You are taking that antioxidant market is booming now. Barabar? Every angioplasty patient, every bypass patient, this thing and that thing, that is invariable addition to the prescription. Does it work? And where it is supposed to work? And what is nature's provision for antioxidant? Though this is not part, just to tell you how we are being fooled. So the mitochondrial, where the oxidation process goes on, that is the point where you need an antioxidant. Does all the things that you take from the food or from the tablet, do they reach mitochondria? No. The only antioxidant into the mitochondrial function is melatonin. And we get it free of cost from the sunlight. You get it free of cost. So melatonin production, 95% of the melatonin is made in the mitochondria. Not at sunlight, not at night, during the day. In the broad day sunlight. Right? What is the antioxidant in the cytoplasm? Glutathione. That is again made from the sulfur containing amino acid. Does your antioxidant berry khao, cherry khao? Isn't it? That's all being this thing. These are all scientific things. You need antioxidant, that is undoubted. But you need antioxidant, proper antioxidant, where it should act. Glutathione is this thing into the cytoplasm, and you need antioxidant in the extracellular fluid and the plasma. This is ceruloplasmin, which is not in the list of antioxidant that you know. Ceruloplasmin is the only antioxidant that works in the blood or the plasma. What are we talking about? Address the basic sciences, and that all can be done with the help of sunlight. Tomorrow or today evening onward, please spend at least 1 hour under the sun. You can do it a lot for your own health. You can't sell it, you can buy it. Cannot. Right? This is extremely important and the only effective strategy. That's why we age prematurely. Why you need to use antioxidant? To prevent premature aging. By not going to the sun, you are aging prematurely. Look into any research, this thing. If at all you want, I will send you the research. That's how it works, right? And basically treat the other causes like inflammation, infection, and drugs. You can't have normal glycemia or normal insulin level in a patient of rheumatoid arthritis, bronchial asthma, psoriasis. No, it is not possible. Because inflammation is counter this thing, right? Now, basic concept, that's what we have been told, what we know, what we think, what we believe, right? You must be knowing lot many protein deficiency disorder. I will sum it up. Isn't it? You must be knowing essential fat deficiency disorders. There are certain essential amino acids and there are certain essential fatty acids that we are supposed to eat. Isn't it? Can anyone tell me here which essential fatty acid can you have from the plant source? Anyone? Essential fatty acids from the plant source? None. None. There is not a single essential fatty acid present or available from the plant source. Right? That's why I'm saying you must eat fat and proteins. They always in nature come together. Does anybody know any carbohydrate deficiency disorder? That's the question I asked to W. Sir when he attended to me, I believe. Isn't it? Is there a carbohydrate deficiency disorder? None. None. Then why are we eating the most non-essential nutrient to the tune of 60%? Or maybe 65% plus. And in Indians it is 85 plus. What is the science and the rationale of eating the most non-essential nutrient to the tune of 80 to 85% in an Indian setting? That's why India is the diabetes capital of the world. Isn't it? So the carbohydrates are non-essential. And what is the recommendation? WHO, ADA, AHA, ICMR, you must eat grains which are into bracket healthy, assumed, to the tune of 60%. And that's what is written in your textbook also. Isn't it? They are not, because what they recommend is written in the textbook. I challenge the textbook, that's what I said. Right? And all starches, that's what I discussed with madam yesterday night. आमचा प्रश्न असतो ज्वारी खायची का बाजरी खायची, गव्हात साखर असते का बाजरीत कमी असते, बरोबर ना? These are the questions we face from the patients and even from the doctors. All the grains contain nearly about 80% of the content, weight to weight basis starches. All the grains. मग मला ज्वारी की बाजरी हा प्रश्न नंतरही विचारू नका. आलं लक्षात? ते कॉमन क्वेश्चन असतात. If you are eating anything containing 100%, 80% glucose, can it be healthy? Would it reduce the insulin level or increase the insulin level? They are digested and digested rapidly. Isn't it? So all the starches are digested and absorbed only as a glucose, and every glucose molecule in the blood stimulates insulin secretion. Every this thing. Right? And fructose is basically fruits. What do you think? Fruits are healthy or unhealthy? Leave aside the practice. आपण फळं खातो, मी पण खातो, हे मला सगळं मान्य आहे. पण can it be healthy from the scientific fundamentals? No. And why no? Because there are plenty of knowledgeable guys on the YouTube say, फळं खाऊन डायबिटीज बरा करा. आहेत ना? रोज सकाळी 1 किलो फळं खा. त्यातल्या त्यात केळं घ्या, द्राक्ष घ्या. बरोबर आहे? पहा तुम्ही यूट्यूबवरती तुम्ही म्हणजे फ्रुटेरियन डाएट म्हणून आहे ते. What nonsense. What is the role of fructose? Do you know any metabolic pathway controlled by the fructose in the body? None. There is not a single metabolic pathway in the in the body which demands fructose. What happens to the fructose? What happens to the fructose we eat? समजा आपण एक केळ खाल्लं किंवा द्राक्ष खाल्ले किंवा ज्यूस घेतला. इथे असेलच ना जेवल्यानंतर ज्यूस प्यायचा की नाही तुम्ही ठरवा. The practices are different, but you must understand the science. Is there a single tissue in the body which can metabolize and utilize fructose? Your answer, please. Is there a single tissue in the body which can handle alcohol? Mind well, if you are eating fruits, you are drinking alcohol. Because the fructose and alcohol metabolic pathways are same. The fructose basically is metabolized only in the liver. Say for example, you are 70 kg weight. Liver is around 1200-1500 gram. That is the only tissue which is supposed to handle the fructose. Can handle the fructose. Rest remaining 69 kg uses glucose and glucose only. Isn't it? No tissue in the body can use fructose except the liver. It has to be detoxified. And what is the detoxification mechanism? It's converting into the fat. And second is converting into the uric acid. You must be getting lot many patients with high uric acid level. Animal डाळ खाऊ नका, protein intake कमी करा, mutton खाऊ नका. If you eat 100 gram of mutton and 100 gram of fructose, which will increase the uric acid more? Huh? Fructose. Have you ever advised the patient of high uric acid to stop fructose? None. Because we do not know. That's what I'm saying. There is huge disconnect between the basic physiology or biochemistry and the application of it. If your uric acid is raised, please stop consumption of fructose first. If you are hypertensive, please stop fructose use first. I repeat, right? For high BP, stop fructose use first. If at all there is some other acquaintance about all these things, I will be happy to tell you. But coming to this is the most non-essential, most non-metabolizable ingredient that we are eating, considering it as healthy. And then the recommendation says so, भरपूर भाज्या आणि फळे खा. बरोबर? मोस्ट नॉन इसेन्शियल. याच्यात मी बोलत असेल काही खोटं असेल, चूक असेल तर मला नक्की सांगा. Do you all agree to the science of it? The practice, obviously you can decide. But I am supposed to tell you the science. Isn't it? Fructose is the most non-essential. And that is the reason you get a fatty liver. When it gets converted to the fat, it's stored in the fat. Right? I will tell you the alternative mechanism. Huh? Vegetables are good. They contain 3 to 5% glucose only, hardly any fructose, less than 1%. That's why they don't taste sweet, isn't it? Basically, it's a deeply rooted idea that fruits are healthy. And we must eat it. Nothing wrong in it. Diabetic can eat fruits. So we eat a glucose and a fructose together. What we measure? Glucose. Have you ever measured fructose? Never. Why? Why? There is something called as first pass circulation. Once you enter, the liver takes it out. It is entered into the circulation through the hepatic circulation, mesenteric circulation. It is taken away by the liver. That's why. And where it acts on the insulin receptors, not on insulin, not on blood glucose. The action of fructose is on the receptors. That I will show in the next slides. And coming to the last misconception that we have been carrying, calories, you must know, you must be knowing the physiology and the anatomy. Are there calorie sensors in the body? What the hell we are counting then calories for? What is the rationale in counting the calories? There is no rationale. That's what I'm saying. The idea was introduced in 1915. And ever since then we started counting calories without any success. There are no calorie sensors in the body. You should not count the calories in the food. Never. What body understands? Satiety and hunger. Please respect that. Body tells you exactly. Right? So there are no calorie sensors in the body. And this is my famous slide. Fructose doesn't, say we have been talking about the insulin. And fructose doesn't spike insulin. Then we are supposed to eat it. And if you compare the fructose with the glucose, what is the extent of damage or negative effect that is creating? 7 times. Including glycation, that we never measure. That is not part of the HbA1c. And that includes famous apple. 100% खाल्लं तो चालेल का? That includes your oranges. Into bracket, all the fruits that you can have. I am telling you the science. If it is anything wrong, you can discuss with your colleagues and please let me know later on also. I am firm on what I am telling. That's what I am saying. मी सुरुवातीला शपथ घेतली की सांगेल ते सत्य सांगेल आणि जे सांगेल ते उपयुक्त असेल. Right? So go to the slides and throw it on anybody. कोणी म्हटलं ना फळं खा, त्याला म्हणा हे काय बाबा हे समजून सांग. हे पहिलं मला क्लिअर करा. So the person who is non-resistant to insulin can have fruits. Never juice or leave aside the cold drinks. That is bad and worst. That even the fruits are only person means advisable to person who is not insulin resistant or insulin sensitive you can call. Right? So this is very important. Even the berries are shown. You can see lower down there in that apple and this thing. Even the cherries are shown. Right? Right? Coming to the insulin response to the food, because this is all related to the way you are going to handle the PCOS. Insulin response to the carbs, if you consider it as 100%, the insulin response to the protein is 50%, and to the fat is 10%. Then if at all you want to reduce insulin into bracket resistant, what you should eat most? Anyone? Fats. Single answer, simple answer. You must eat fats, I repeat fats, to decrease the insulin and insulin resistance. आणि आम्ही काय सांगतो, एक्झॅक्टली डायगोनली अपोजिट, साय काढलेलं दूध घ्या. कुठून हे कोणाच्या डोक्यातली आयडिया आली मला कळालंच नाही. याच्या इतकं मूर्खपणाचा ॲडवाइजच असू शकत नाही. हा, फुल फॅट मिल्क, म्हशीचं साय न काढलेलं दूध हे अतिउत्तम आहे. यू विल फाइंड युअर शुगर लेवल गोइंग डाऊन, इन्शुलिन लेवल गोइंग डाऊन, you will feel satiated, lesser hunger. Barabar? So you need, what is the, basically there is a lactose molecule in the milk and there is a fat molecule in the milk. How they are existing in the milk itself? It's a lipopolysaccharide. The sugar molecule is covered by the fat. So you don't get that much worse effect. Definitely it contains glucose and galactose. Lactose is there. I am not denying that. But you must consider the way it exists. What we consider milk as a protein, carb, fat, sodium, electrolytes. Do you mean to say it is a chemical liquid? Is it a chemical liquid or is it a biological liquid? What happens to the biology when you standardize it, homogenize it, and pasteurize it? And that to be in a plastic bottle. So all the biological content, all the biological entities are destroyed. आणि ते देखील असतं, त्याच्यात आम्ही साय काढायला सांगतो. अजून वाटोळं. इट्स सिम्पली इन्सेन. काय बोल, ठीक आहे, सिन्स युअर प्रोटोकॉल सेज नो क्वेश्चन्स. So if at all you want to reduce the insulin, you must eat fat. But which fat? Not refined oils. Don't jump onto that. Eat all naturally available form in the natural form. Very simple. Very simple. Right? And then आम्हाला कोणते सांगतो ते प्लांट बेस्ड आणि यावं त्या, बरोबर ना? The science says the animal proteins are far superior than the plant source. Right? The plants concentrate their toxins in the seeds. So the seed oils, especially the refined oils, are bad. लाकडी घाण्याचं तेल देखील वाईट. सोयाबीन सगळ्यात वाईट. बरोबर, इथे हॉटेलमध्ये आल्यानंतर एक पार्टी आहे की आमच्याकडे सगळे पदार्थ सोयाबीन ऑइलमध्ये केले जातात. म्हणून लागली वाट आपली, म्हणून मी सकाळी वडा घेतला नाही. आणि प्रोटीनचा प्रश्न आला की आपल्याला एक फार मोठं, आम्ही फार स्वतःवरती उपकार करतो असं आहे भाषेमध्ये आपण सांगतो, खातो की डाळी, कडधान्य खातो की, बरोबर ना? हेच उत्तर असतं. तुमच्या मनात तेच आहे. आणि तुम्हाला गंमत सांगतो, एका नांदेडला मी भाषणाला गेलो होतो आणि मग तो असंच ते काहीतरी चाललं होतं त्यांचं. मग मी त्या म्हणजे जाहीर नाही प्रश्न विचारला, मला माहिती होतं चड्डी सुटेल म्हणून. मग मी आपल्याला खाजगीत एक प्रश्न विचारला, अरे बाबा, जे कडधान्य म्हणून तुम्ही जे काय सांगितलं, सगळं जे काय सांगितलं आहे त्याच्यामध्ये प्रोटीन असतात, मला मान्य आहे ना, मग किती असतात हे तरी सांग ना तू. भाषणात नाही सांगितलं, मला खाजगीत सांग, मला माहीत नाही म्हटलं. काय सांगावं त्या माणसाने उत्तर? 60%. म्हणजे आमच्या शेतकऱ्याच्या भाषेत हात माझ्या तोंडात. इट इज ॲब्सोल्युटली अनसायंटिफिक नोशन्स दॅट वी आर कॅरिंग अँड डिस्कसिंग अँड प्रेझेंटिंग फ्रॉम द डायस. अँड इमॅजिन अ नॉन मेडिकल पर्सन सिटिंग इन फ्रंट ऑफ यू, ही कॅरीज इट एज अ सायन्स, ही प्रॅक्टिसेस इट. कडधान्यामध्ये प्रोटीन आहेत म्हणजे धान्यापेक्षा 10% जास्त आहेत. दॅट इज द करेक्ट सायन्स. मग राहिलेले 80% काय आहे? कार्बच आहेत. For a non-diabetic person, especially for your PCOS patient, when you are replacing pulses for the grains, it is good. Not for a person who is diabetic. Preferably no pulses also, but what you are replacing it with. हे धान्यापेक्षा कडधान्य चांगले, हे बरोबर आहे. म्हणून कडधान्य चांगले हे वाक्य चूक आहे. पण तुमच्या PCOS पेशंटचा ग्लायसेमिक कंट्रोल चांगला असतो. म्हणजे दे आर नॉट, म्हणजे तुम्ही GT जरी केली तर दे डोंट क्रॉस दॅट बॉर्डर. सो यू कॅन यूट एज अ रिप्लेसमेंट. म्हणजे भाकरीच्या ऐवजी थालपीठ द्या. एक सोपं त्याचं वर्जन सांगतो मी. आणि नंतर ते न्यूट्रिशनल केटोसिस विषयी एक फार गोंधळ असतो. माझ्या IMAच्या मागच्या भाषणात पीपल वर क्वेश्चनिंग Nutritional ketosis is healthy, normal state of the health. All the children are born with ketosis. The child, when it is born, he is in a frank ketosis. Right? That's why they go land in hypoglycemia. Hypoglycemia should be prevented. Ketosis should not be disturbed. Just for the sake of information, मी तुम्हाला सांगतो, गेली 12 वर्ष मी किटोजेनिक डाएटवरती आहे. साधारणतः 50 वेळा माझी स्वतःची युरिन केटोन्स केलेले आहेत. दे ऑलवेज आर, आय एन्श्योर दॅट इट इज पॉझिटिव्ह. दॅट इज कॉल्ड एज न्यूट्रिशनल केटोसिस. नथिंग रॉंग, नथिंग बॅड, ॲब्सोल्युटली नॉट. आणि मग ते आम्ही न्यूट्रिशनल केटोसिस हे केटोॲसिडोसिसच्या थरावरती नेऊन ठेवलेलं आहे. Ketoacidosis is bad, no question about it. It's an emergency. Doesn't mean nutritional ketoacidosis is bad. Me and my wife both, without hunger, can fast for 9 days without a problem. I completed all my marathons, 25 plus, in fasting stage. Nothing extraordinary. म्हणजे याच्यामध्ये काही चूक आहे की नाही हे आम्ही परखून घेतलं पाहिजे. की डॉक्टरकडे स्टेजवरती आले माईक मिळाला म्हणून काहीतरी बडबड करतात का? वेदर न्यूट्रिशनल केटोसिस इज हेल्दी, इज इट रिअली हेल्दी इन अ शॉर्ट टर्म ऑर अ लॉंग टर्म? द आन्सर इज हेल्दी अँड यू कॅन डू इट फॉर लाईफ अँड यू शुड डू इट फॉर लाईफ. नथिंग रॉंग. अँड देन द कोलेस्ट्रॉल. राईट? ऑल द रिसेंट सायन्स, including the Minnesota coronary trial, the biggest trial ever done, says that cholesterol is not bad. Right? Since it is gynecologist, I will just skip it over. Then so much so about the theory part of it, how to proceed with the actual management of PCOS. That is important. Right? So the food is the most important modifiable factor in insulin resistance. If you treat insulin resistance, I am very sure that your patient will come back to normal physiological cycles or menstrual cycles and everything. We have yet to use a single drug, even metformin, yet to use. Last maybe 10 years we have been practicing, not a single drug used. Right? Coming to what actually should be the plan of action, I have given you the theoretical background enough. Right? Most important factor is what not to eat. And that means processed food. Anything that is packaged, bottled, marketed, advertised and branded is bad. Even then we find, yesterday madam only quoted, काही ते डायबिटॉलॉजिस्ट आहेत, 4 मारे बिस्किट चहाबरोबर सकाळी आणि 4 मारे बिस्किट संध्याकाळी. बरोबर आहे ना? बरोबर आहे? मी बोलत असेल तर खोटं असेल तर सांगा ना मला. दिस व्हॉट वी ॲज अ डायबिटॉलॉजिस्ट ॲडवाइज, ॲज अ डायबिटॉलॉजिस्ट. Simply cannot think of it. Outright scandalous, unscientific, and detrimental to the glycemic control and health of the patient. If it is packaged and processed, it is bad. Make it simple. And then there are diabetic biscuits, high protein biscuits, digestive biscuits. What nonsense. I have never heard, IMA or Foxy talking against it. It is our job, sir. It is our job. Because it's not a patient, it is our kids are also suffering. We continue the same. कारण आपल्या समोरचं शेजारचं पोरगं बिस्किट खात असतं आणि आपण एका डॉक्टरने लिहून दिलं आहे. डॉक्टरने लिहून दिलं सांगतात नाश्त्याला पोहे वगैरे ते तो भाग वेगळा सोडून द्या. पण दिस इज कॉमनली प्रॅक्टिस इन अ पेशंट विथ PCOS. They are all in their 20s and something like that. Heavily indulging into the processed food. Right? With एक लक्षात ठेवा, साखर, मैदा आणि तेल ज्याच्यामध्ये आहे ती गोष्ट खायची नाही. एवढं जरी एक वाक्य तुम्ही माझ्या भाषणातून घेतलं आणि प्रॅक्टिस केलं, नथिंग डिफिकल्ट अबाउट इट, तरीही तुमचा प्रॉब्लेम 50% सुटलेला असेल. 50% पेशंटला याच्यापुढे जायची गरजच नाही. साखर, मैदा आणि तेल कुठलंही बंद. बरोबर? मी भाकरी म्हटलेलं नाही, चपाती म्हटलेलं नाही, भात म्हटलेलं नाही, डाळ म्हटलेलं नाही. बरोबर? हे सगळं तुम्ही खाऊ शकता प्रोव्हाइडेड यू आर न्यू इन दी डिसीज प्रोसेस. बरोबर? हे जर खायचं नाही आणि अजून कमी काय करायचं? डिपेंडिंग ऑन द सिव्हिरिटी ऑफ द प्रॉब्लेम, हाऊ ओल्ड इज द पेशंट. म्हणजे 30च्या पुढं असेल विशेषतः किंवा 25च्या पुढं असेल. एक्सपेक्ट चाइल्ड दॅट प्रोटोकॉल अगेन फॉलोज दिस. बट यू कॅन रिड्यूस कॉन्फिडंटली ग्रेन्स, लेग्युम्स, स्प्राउट्स, दाल अँड फ्रूट्स. हे कमी करा, म्हणजे वरचे प्रोसेस फूड बंद आणि हे कमी. शून्य मी म्हटलेलं नाही आहे, कमी. म्हणून मी काल एक साधा माझ्या एका डायबिटीसच्या पेशंटला प्रोटोकॉल दिला की 2 चपात्या खातो बाबा, त्याच्याऐवजी एकच खा आणि मला आठवड्याभराने कळव की तुझी शुगर कशी काय कमी झाली. राईट, द पेशंट इज सिटिंग राईट इन फ्रंट ऑफ मी. दॅट अ पार्ट. अँड व्हॉट टू इन्क्रीज. हे जर खायचं नाही तर काय खायचं बाबा, हे कमी खायचं आहे तुम्ही सांगितलं, हे मला मान्य, पण काय खायचं हे तर सांगा आधी. द ॲन्सर लाईज इन व्हॉट नॉट टू ईट. आणि त्याच्यानंतर त्याचा कॉन्ट्ररी अप्रोच येतो की व्हॉट टू ईट. व्हेजिटेबल्स, सगळ्या भाज्या, नो एक्सेप्शन. मग कोण म्हणतो ते वांगं चालतं का, गवार चालतं का, बरोबर ना. हे सगळे आपले प्रश्न असतात. दीज आर ऑल अनसायंटिफिक नोशन्स व्हॉट वी हॅव बीन कॅरिंग. अँड फुल फॅट डेअरी, साय असलेलं म्हशीचं दूध, सुंदर, बरोबर. मस्त 1 ग्लास सकाळी आणि 1 ग्लास संध्याकाळी घ्यायला काय, म्हणजे 250 ml सकाळी आणि 250 ml संध्याकाळी, म्हणजे PCOD आय एम टॉकिंग अबाउट. नो हार्म डन, राईट. अँड देन ऑल ॲनिमल सोर्स फूड. मी एका माळकरी घरातला माणूस आहे. तुमची आणि माझी संस्कृती जवळजवळ सारखीच आहे. मांसाहाराविषयी माझ्याही काही संकल्पना होत्या, भावना होत्या, विचार होते, आणि ते सगळे अशास्त्रीय होते हे देखील मी सांगतो. व्हेन आय रिअलाइज दॅट वॉट यू आर प्रॅक्टिसिंग इज अनसायंटिफिक, देन आय शिफ्टेड. आमच्याकडे पाणी पण ओलांडत नाहीत. म्हणजे समजा भांडं धुवून तुम्ही पात्र्यातलं पाणी मांसाहाराचं जर टाकलं तर शाकाहारी म्हणून पाणी पण ओलांडत नाही ते. म्हणजे इट इज टू दॅट एक्स्ट्रीम एक्सटेंट. ओके, प्रत्येकाच्या भावना असतात, त्याच्याविषयी मी बोलणं चुकीचं आहे. पण यू कॅन डेफिनेटली इन्क्रीज दोज हू आर कम्फर्टेबल विथ ॲनिमल सोर्स फूड. यू कॅन डेफिनेटली गो फॉर ॲनिमल सोर्स फूड ईच अँड एव्हरी. म्हणजे अंडी पिवळ्यासहित, हे पुन्हा एकदा सांगतो. अँड व्हेन टू ईट, ॲज आय सेड, calorie doesn't matter, you need to reduce frequency, and if you eat properly, the body tells you to eat at a proper time depending on your exercise schedule or activity schedule. मग भूक लागली की खा. पण खा म्हणजे काय, आम्हाला 4 बिस्किटाची भूक असते ते नाही, पोटभर जेवा. समजा तुम्हाला 5 वाजता भूक लागली ना, मांडी घालून बसा, ताट वाढून घ्या, पोटभर जेवा. दॅट्स हाऊ आय ॲडवाइज ऑल माय पेशंट्स की भूक लागली की पोटभर जेवा, बरोबर. नो कॅलरी काउंटिंग ॲट ऑल. And how much to eat? Till you are full. पोट भरलं की. If you eat unprocessed, the insulin level goes down, leptin level comes up, body tells you to stop at a proper time. तुम्ही ग्लासभर ज्यूस पिऊ शकता, भाजी पोळी खायचं म्हटल्यानंतर वेळ जातोच. सो दी बेसिकली satiety signals takes around 20 minutes. K cells in the duodenum and L cells in the ileum, jejunum. They give the variety of cholecystokinin and all other peptide YY satiety hormones, and obviously the brain gives you the leptin that sends you the satiety signals. So eat when you are hungry, do not eat if you are not hungry. हे सगळे अवघड आहे की वेळ झाली, नवरा आला, पोरं आली, वास आला, निमंत्रण आलं, पाहुणे आले. सी दीज आर ऑल द रिझन्स फॉर विच वी आर इटिंग. मग मी गमतीने माझ्या पेशंटला तेच नेहमी सांगत असतो की समजा तुम्ही माझ्याकडे आलात आणि आता घरी परत झाला, दिसेल त्या पेट्रोल पंपावर ते पेट्रोल भरत जाणार का तुम्ही, बरोबर की नाही. काय टाके खाली झाली तरच भरणार ना तुम्ही. इट इज दॅट इझी. ईट फुल वेन यू आर हंग्री, अँड देन द बॉडी टेल्स यू वेन टू ईट अँड वेन नॉट टू ईट, बिकॉज देर इज अ ह्यूज इंटरप्ले ऑफ हार्मोन्स इनसाइड. रिस्पेक्ट दॅट. म्हणजे नुसतं इन्शुलिन आहे, नुसतं अमुक आहे, तर मग असं नाही. इन्शुलिन जाऊन वरती हायपोथॅलॅमसला सांगतं, तिथून लेप्टिन तयार, हे इकडचे फॅट टिश्यू तुम्हाला लेप्टिन देऊन तिकडे सांगतात की नाही आता पोट भरलं, बाद झालं. कोलेसिस्टोकायनिन सांगतं आता फॅट भरपूर झालं. पेप्टाइड वाय सांगतं प्रोटीन भरपूर झालं. यू हॅव गॉट एव्हरी सेन्सर्स इन द बॉडी एक्सेप्ट द कॅलरी सेन्सर्स, राईट. अँड ऑब्वियसली what to add. See, the life nowadays is a high stress thing. So those who can and those who need. म्हणजे तुम्ही पेशंट पाहिल्यानंतर तुमच्या एक असेसमेंट लक्षात येतं, घरचं स्टेटस काय आहे, अँक्शस आहे की नाही, स्ट्रेस इश्यू आहे की नाही. द पेशंट हू कॅन अँड हू नीड शूड गो फॉर मेडिटेशन. आणि त्याच्यामध्ये इफ यू टेक हेल्प ऑफ अ न्यूरोसायन्स, व्हेन वी कॅनॉट थिंक इज व्हेन द ब्रेन इज व्हायब्रेटिंग. हे proved neuroscience आहे की when the brain receives vibration, then it cannot think. Overthinking is a common problem at that age. त्यामुळे भ्रमरी प्राणायाम, तोंड बंद करून असं this is Brahmari, and it stops thinking. You can do it yourself for 5 to 10 minutes. It stops, best solution for anxiety. कुठलाही प्राणायाम करा, especially if you have got a stress, overthinking, lack of sleep, go for Brahmari. It works, it helps and free of cost. Right? 5 मिनटं, माझा जो ॲडवाईस असतो की सकाळी उठल्यानंतर 5 मिनटं आणि रात्री झोपताना 5 मिनटं. 5 मिनटं भ्रमरी प्राणायाम अवश्य पाहिजेत. इफ यू आर स्ट्रेस आउट थिंकिंग, या पेशंटचं काय होणार त्या, म्हणजे लिव्ह असाइड द PCOS ऑल्सो, यू ऑल्सो कॅन प्रॅक्टिस इट. इट इज व्हेरी इझी. अँड आउटडोर एक्झरसाइज. Sunlight is an essential part of your health. If there is no sunlight, there is no health. Right? Very important. And sleep. Being a gynecologist, you cannot assure the sleep. Right? That is the worst part of the theory. And then take care of the screen time. PCOS patients I am talking about. Right? Screen time is the biggest disruptor of your sleep, mood, activity schedule. Right? And stress management, as I said earlier, and addiction. I run an addiction center with an indoor capacity of 300. 300 patients admitted as on date, 100% occupancy. You can imagine the incidence or prevalence. Huge. Even in teens, I am talking about. Even in teens. If you fail to ask, the patient will not say anything. And that includes mobile addiction. It includes mobile addiction. Right? माझ्याकडे म्हणजे कित्येक मुली मोबाईलच्या ॲडिक्शनसाठी ॲडमिट आहेत. They cannot do anything else but watching mobile. Right? And the problem is going to escalate in the near future also. So the addiction is every nature. म्हणजे पुण्यातल्या किंवा मोठ्या शाळांच्या बाहेर तुम्हाला सगळी ड्रग्स फुल्ली अवेलेबल आहेत. ऑल बॅन ड्रग्स. सगळ्या शाळांच्या बाहेर. Supplier knows how to sell, how to catch the गिराईक. Right? So the addiction, especially the area where I am working, is a very, very big problem. I think here also situation must be the same. Addiction very common. So take care of addiction, and if at all there is some other drug for some other reason, the girl is using, and the microplastics. As I said, water bottles, and at that age, chewing gum. Chewing gum. The girls use at least 5 chewing gums a day. Extremely bad. Many a times you find, because we do not ask for it. तुम्ही chewing gum खाता का, हा हिस्ट्रीमधला प्रश्नच नाही आपल्या. बरोबर, पाळी किती दिवस येते, किती दिवस पॅड बदलतात, पेन येते की नाही, काय येते की नाही. But chewing gum we never ask. Since it is never asked, it is not, म्हणजे इन्फॉर्मेशन देतच नाहीत ते. So please ask in a suitable patient. Right? And this is what we do at our center. If the child, the patient is 15 years around something, what do we advise? Stop processed food. All and every sweet. Go in the sun and play. Right? And mobile control and sleep. And if you follow this, I am 100 out of 100 can assure you the success in the management. This is only. What is so difficult in it? याच्यातली कुठली गोष्ट आहे जी तुम्ही करू शकत नाही, पेशंट करू शकत नाही, खर्च येतो, सुविधा लागते. We fail to understand the issue, basically. If the patient is around 25 years old, waiting to get married, म्हणजे माझं आता लग्नात मुलगी दाखवायचं आहे, असं ते असतं ना सगळं. मग त्याच्यातला जर पेशंट असेल तर what we do, obviously the stop processed foods, then we start with the low grain approach, low carb, high fat, that is LCHF. तिला चांगलं रोज सकाळी साईचं एक वाडगाभर साई खायला सांगतो. हां, शेंगदाणे खोबरं खायला सांगतो, बदाम अक्रोड खायला सांगतो, पण चपाती 2च्या ऐवजी 1 किंवा अर्धी करायला सांगतो. अत्यंत सोपं आहे. बरोबर. आणि अदर मेजर्स म्हणजे त्या वयामध्ये लग्नासाठी करता एन्झायटी इज ऑलमोस्ट ऑलवेज कॉन्कॉमिटंट फॅक्टर इन दी पेशंट. आणि मग बाकीच्या गोष्टी मेडिटेशन आहे, हे जे सगळे त्याच्यामध्ये येतात. पण द न्यूट्रिशनल अप्रोच इज स्टॉप प्रोसेस फूड अँड इंट्रोड्यूस LCHF, लो कार्ब हाय फॅट डायट. इफ इट इज 30-year-old married woman and hoping for a child, right? Then both the parents I do not advise the individual. Then both the husband and wife both should be included, right? Difficulty in getting pregnant. Then stop processed food. LCF is another. Protocol is same, but for both. It is absolutely essential to have a baby and healthy baby. मी सांगतो त्याशिवाय होणारच नाही. Both of you are sick, that's why you are not getting conceived. The wife is not getting conceived. So you must improve your health along with your wife's health. Then I catch hold of the husband first, because that time he is the dictator. So if you talk to the husband, then the family works. Then if it is 35 years, failed assistance in that IVF or what all things you do, if it is failed assisted pregnancy, then the real problem comes, right? They have spent their money, exhausted, depressed, fatigue. काही करा पण आम्हाला बाळ पाहिजे ह्या लेवल. आणि कालचं प्रकरण त्याच्यातलंच आहे, मंगेशकरांचं प्रकरण त्याच्यातलंच आहे. दो दी मदर हॅड सम अदर दिस थिंग, पण दे आर म्हणजे अगदी असे म्हणजे एकदम फ्रस्ट्रेटेड असतात, डेस्परेट असतात. आणि देन द प्रॉब्लेम कम्स. देन आय ॲस्क देम टू विजिट मी एव्हरी 2 weeks with a proper advice, both the parents again. Then stop processed food. Then rather than waiting, I start with the keto. Keto is no grain, not reduced grain, but no grain. No grain pulses and fruits at all. And then put them on either a vegetarian diet or a non-vegetarian diet, mainly proteins and most of it fat. That's called as a keto diet. And then, if it is third attempt IVF failed, then I put them on fasting. At least 30, म्हणजे एकादशीचा उपवास, दशमीला धरायचा आणि बारशाला सोडायचा, 36 तासाचा उपवास, आठवड्यातनं 1 दिवस, दोघांनी पण. दिस इज द स्टँडर्ड प्रोटोकॉल. आणि हाय इंटेन्सिटी इंटरवल ट्रेनिंग एक्झरसाइज. हाय इंटेन्सिटी इंटरवल ट्रेनिंग सोप्या भाषेत आम्ही असं सांगतो की जनरली तुम्ही व्यायाम करता का असं विचारलं तर पेशंट म्हणतात हो करतो की. मग आम्ही विचारतो काय करता, जातो की सकाळी चालायला. किती वेळ, 45 मिनटं 1 तास तर जातातच डॉक्टर, चांगला कामगाम होतो. म्हणतो छान आहे. फक्त एकच सांगायचं आहे त्यांना की 1 मिनटं पळायचं आणि 2 मिनटं चालायचं. 1 मिनटं पळायचं, 2 मिनटं चालायचं, एवढं सोपं काम तुम्ही करा आणि इट वर्क्स वेल. अर्थात याच्या पुढे देर आर अदर ॲनाटॉमिकल डिस्टर्बन्सेस विच आर रिस्ट्रिक्टिंग द चान्सेस ऑफ प्रेग्नन्सी, दॅट इज टू बी डेल्ट सेपरेटली. बट सिम्पल PCOD going into that extent, because the IVF center do not advise anything out of this. मग ते हार्मोनल हे देणार, सुरुवातीला IUI करणार, मग ते काहीतरी ऊसाईट काढणार, ते फर्टिलाइज करणार, प्रिझर्व करणार, किंवा हे म्हणजे ऑल सॉर्ट ऑफ थिंग, यू नो इट बेटर दॅन मी. आणि हा सगळ्यामध्ये ते म्हणून मग पेशंट अशा वेळेस काय होतं की आय डिस्टिंक्टली रिमेंबर अ पेशंट की त्यांना मी म्हटलं अंडी खा, तर त्यांनी विचारलं किती खा, म्हटलं किती पण खा. ते म्हणाले पोटभर, हो म्हटलं पोटभर. अँड देन जी स्टार्टेड क्राईंग. म्हणजे डॉक्टर, मी 10 वर्ष डॉक्टरकडे जाते, 25व्या वर्षापासून एकाही डॉक्टरने पोटभर खा असं मला सांगितलेलं नाही. नॉट अ सिंगल. ह्यूज फेल्युअर फ्रॉम आवर साईड. हंगर इज अ इनव्हॉलंटरी रिफ्लेक्स. यू कॅनॉट कंट्रोल इट व्हॉलंटरीली. यू कॅनॉट. देन यू ब्लेम द पेशंट. काय तुम्ही ऐकलं नाही, तुम्ही केलं नाही, असं झालं तसं झालं. बरोबर ना. आमचं चुकलं की नाही हे आम्ही विचारतच नाही, पाहतच नाही, तपासतच नाही. द लेडी लिटरली क्राईड इन फ्रंट ऑफ मी की म्हणे डॉक्टर मी इतक्या डॉक्टरांकडे जाऊन आले, त्यांनी सांगितलेलं मी सगळं केलं, पण कोणी मला पोटभरचे असं नाही सांगितलं. हे एवढंच खा, ते 1200 कॅलरीजच खा, 1200च्या पुढे जाता कामा नये, थोडं कमीच खा. म्हटलं मॅडम मी तुम्हाला सांगतो ते करा. आणि शी इज हॅपीली कन्सिव्ड ऑन 4th month, right? And if at all, there are obviously a few patients who may not get a result. We wait for 3 to 4 months before starting the drug therapy. And the first is the metformin. Then again 3 to 4 months, then we use some other ovulation inducing drugs and other thing. That we hardly ever use, not even 1% of the patients. Coming to the challenges in the management. Challenges with the doctors. That was the original topic given to me. Then it shifted to MAIS in PCOS management. What we learn in the medical college? Do you think you have got a sufficient information or the knowledge or acquaintance from your textbook or the undergraduate or postgraduate learning about the nutrition? आम्हाला न्यूट्रिशन म्हणजे काय, त्याच्यात इतकं असतं, ते हे विटॅमिन घेतल्याने हे होतं, नाही घेतल्याने ते होतं. याच्या आपल्याकडे आमचं न्यूट्रिशन काय आहे MD लेवलपर्यंत? Please accept the fact that we know nothing about nutrition. We need to study and study. If at all, the one who think that they are studied well, you need to study again. We need to study. Get into the basics. It is very easy. Anyone can do it. If a person like me can do it, you are much better eligible to do it. Right? So we must learn. And the recommendation that we get from our professional bodies, like Diabetes Association, Heart Association, Gynec Association, we must scrutinize. If at all something you don't understand, get a clarification. And if you don't accept, please ask for a change. Please ask for a change. Gynecologists can do it well. Because you are not so much obsessed or badly treated in the field of education. Physicians are very badly managed so far as the education is concerned. I am talking about lifestyle. Well, the infection, heart attack and this thing, we are the masters, no doubt. But we must learn the things and should be able to apply it properly, right? And just change your focus from the symptom to the cause. Anything comes in front of you, we start writing the prescription. Give patient listening, have a 1-page pro forma or 2-page pro forma. I got a 4-page pro forma for the history taking. He has experienced it. So we have got a dual history taking system. The person attends to, comes to the clinic, attends to the nursing station first with equal parameters, give the history of dietary history, and then attends to me. And then again I start history taking. But since the system is working for last 11 years, the understaff is trained nicely, and they know where to catch. What are the catching points? What to ask and what not to ask? What does it mean? Right? So that is extremely important, the history taking of the daily lifestyle of the patient. That is never a part of our history taking teaching or anything. तुम्ही बिस्किटं खाता की नाही आपण हिस्ट्रीमध्ये कधीच कोणाला विचारलेलं नाही, विचारा म्हणून आम्हाला त्याचं महत्त्व माहीत नाही आहे. आणि आपला सगळ्यात मोठा गुरु कोण असतो? महागुरु यमार, हेविली इन्फ्लुएन्शियल. तो जे बसून सांगतो ते आपल्याला रामायणापेक्षा जास्त पवित्र असतं, मान्य असतं. बरोबर, आपण त्याला विचारतच नाही. मग मी काल गोष्ट सांगितली असेल माझं चंद्रकांत, एका मोठ्या प्रॉडक्टच्या लॉन्चला मी गेलो होतो. म्हणजे मी चीफ गेस्ट होतो तिथे. ते ह्या डॉक्टरांच्या हस्ते यांची प्रॅक्टिस खूप जोरात आहे आणि मग यांच्या हस्ते आपण त्यांची बायको गायनॉलॉजिस्ट यांच्या हस्ते आपण ते प्रॉडक्ट लॉन्च करू. म्हणजे तेव्हा ते पहिल्यांदाच प्रॉडक्ट मार्केटमध्ये आलं. तो मॉलिक्युलर्स इंडियामध्ये पहिल्यांदा आला होता. आणि बाकी स्टोरी मी सांगितली, कट इट शॉर्ट. मी त्यांना म्हटलं तुमचं हे प्रॉडक्ट पूर्णतः अशास्त्रीय डब्यात फेकून द्यायच्या लायकीचं आहे आणि तुम्ही वाचू शकता आजही. आणि टेल मी द सायन्स. So the drug acting at a pro-megakaryocyte level, how can you use it as an emergency treatment for bleeding? असं होऊ शकतं का? Pro-megakaryocyte do not have any thrombotic action, doesn't help in or doesn't participate in coagulation mechanism, either extrinsic or intrinsic. How the drug that is acting at the pro-megakaryocyte level can be used for bleeding, to stop bleeding in a cesarean section, in a wound? Cannot. You all are prescribing. बरोबर? अभ्यास तर करा. It is not proper for me to divulge this thing, but you can talk to Chandrakant. It takes around 3 weeks for the pro-megakaryocyte to mature platelets. How the drug can act within 2 minutes? How can it act? म्हणजे डॉक्टरांना काही अक्कल नाही, ते विचार करत नाहीत, हे त्यांनी अज्यूम केलेलं आहे आणि आपण ते सिद्ध पण केलेलं आहे बाय युझिंग इट. कोणी pro-megakaryocyte म्हणजे pro-megakaryocyte ते म्हणजे इथामसिलेट हे मॉलिक्यूल आहे. इथामसिलेट हाऊ इट वर्क्स. आणि दुसरं तुमचं शिराशिओपेप्टाइडेज, तिथं काल मी बोललो नाही. शिराशिओपेप्टाइडेज पॉलिपेप्टाइड, त्याचं जे पेटंट आहे त्या कोरियन कंपनीने नेटवरती आहे, तुम्ही पाहून घ्या. दे हॅव सेड, म्हणजे ते ज्या ओरिजिनल कंपाऊंड होती त्यांनी प्रॉडक्ट बंद केलेलं आहे. त्यांनी वेबसाईटवरती टाकलं आहे की दिस ड्रग इज इनइफेक्टिव्ह, आणि तरीही आम्ही वापरतो. आता मला सांगा, डू यू हॅव द कॅपॅसिटी टू ॲब्सॉर्ब पॉलिपेप्टाईड? कॅन वी ह्युमन डायजेस्टिव्ह सिस्टम ॲब्सॉर्ब पॉलिपेप्टाईड? If you drink, eat or something in the tablet form, so what we are ingesting is polypeptide. What happens in the digestive system? It metabolizes to the amino acids. We can absorb amino acid. म्हणजे तुम्हाला असं म्हणायचं की आपल्यामध्ये असा RNA आहे की तो बाहेर आलेलं अमायनो ॲसिड रक्तामध्ये आल्यानंतर पुन्हा सेरेशो पेप्टाइड्स तयार करतो, बरोबर ना? तरीही वापरतो आपण, वापरतो ना सेरेशो पेप्टाइड्स. सूज आले की सेरेशो पेप्टाइड्स. इफ एट ऑल यू कॅन यूज ॲज अ डर्मा पॅच. बरोबर डायक्लोफेनॅक बरोबर हे चालू राहतं ते सेरेशो पेप्टाइड्स, इब्युप्रोफेन बरोबर सेरेशो पेप्टाइड्स. ते काय सूज असते ना म्हटले. अरे म्हटलं ते सेरेशो पेप्टाइड इथून गेलं ती तिथं कसं काय जाईल मला सांग ना बाबा. इट इज इम्पॉसिबल फिजिओलॉजिकली अनलेस यू यूज अ पॅच. Where it can be absorbed locally, goes into the circulation directly as a polypeptide. आम्ही टॅबलेटमध्ये घेतो, आणि यू अँड मी ऑल आर डुईंग दिस, इस्पेशली द ऑर्थोपेडिक सर्जन. म्हणजे त्यांना म्हणजे, आणि तुम्ही त्या कंपनीची वेबसाईट जाऊन पहा सर, कोरियन कंपनी आहे. मी एका फार्मा कंपनीचा मालक होतो, तुम्हाला सांगतो. माझी स्वतःची कंपनी होती फार्माची, म्हणून मी सांगतो की माझ्या प्रॉडक्ट मॅनेजरनी माझ्याकडे आणलं की सर सेरेशो पेप्टाइड्स आपल्याला लई सगळीकडे विकतात, आपल्याला करायचं म्हणजे आपलं काम सोपं होईल. मी म्हणलं गाढवा, त्याचं वेबसाईट पाहिली आणि त्याचा अभ्यास कर, आणि मोड ऑफ एंट्री, डोसेस आणि हे सगळं मला सांग. आणि दोन्ही का सर हा सगळा बावळटपणा चालला आहे. अरे म्हटलं त्याच्यातही आपण सामील व्हायचं का म्हटलं. मग एनीबडी टेल मी द सायंटिफिक जस्टिफिकेशन इथामसिलेट ॲज अ इन द फॉर्म ऑफ टॅबलेट, इंजेक्शन, and serosopeptide in the form of tablet. Please let me know. If I am wrong, I will correct myself. No hesitation at all. So whatever the physiology I know, it is absolutely unscientific to use those drugs. Right? So the overlooking the science of nutrition and lifestyle. We are highly influenced by the pharma. आणि आपल्याला ते त्या अन्नामध्ये काही ताकदच आहे किंवा त्याच्यामध्ये एवढे इफेक्ट आहेत, पोटेन्शियल्स, हे आम्ही मान्यच करत नाही, कारण आम्ही शिकलोच नाहीत. दुर्दैवाची गोष्ट आहे की अन्न हे पूर्ण ब्रह्म, हे रामदासांनी सांगितलेल्या संस्कृतीचे आपण वारस आहोत. आपल्या संस्कृतीचा भाग आहे. अन्नाला आपण पूर्ण ब्रह्माचं स्थान ऑलरेडी दिले आपल्याला 300 वर्ष. वेअर डज इट स्टँड? अन्न हे पूर्ण ब्रह्म म्हणजे पिझ्झा? आर वी इन्सेन? नोबडी स्टूड अगेन्स्ट इट. इट इज आवर रिस्पॉन्सिबिलिटी की आम्ही सांस्कृतिक आमची शिकवण काय आहे की अन्न हे पूर्णब्रह्म. रामदासांना पाव माहीत नव्हते, वडापाव माहीत नव्हता, लिहिलं त्यांनी एवढं. याच्यापेक्षा चांगलं गायडन्स तुम्हाला काय पाहिजे तुमच्या संस्कृतीकडून, तुमच्या इतिहासाकडून, तुमच्या समाजाकडून? आपण करंटे आहोत माझं म्हणतं आहे, ट्रूली करंटे आहोत. की आपण एवढ्या मोठ्या माणसाने आपल्याला एवढं चांगलं विधान दिलेलं असताना आपण त्याचा अवलंब करत नाही. म्हणजे अन्नाची ताकद डॉक्टरांनाच माहीत नाही आहे की एक चपाती काढल्याने इन्सुलिन कमी होईल, हे आम्ही विसरून गेलो, समजूनच घेतलं नाही, प्रॅक्टिसच केली नाही. आणि म्हणून आजच्या गोंधळामध्ये आपल्या स्वतःला ह्या आजारांचं प्रमाण डायबिटीसच्या डॉक्टरांमध्ये काही कमी नाही आहे. तुमच्या आमच्या मुलीबाळींमध्ये, सुनांमध्ये PCODचं प्रमाण कमी नाही आहे. कारण आपण ही ओढ विसरलो, रामदासांना विसरलो. त्याच्यात काय आम्ही शिकलो म्हणजे आमच्या स्टेतो आला म्हणजे आम्हाला अक्कल आली असं आम्हाला वाटायला लागलं. Isn't it? We are far away from this wisdom. Far away from the wisdom. Please understand everything. It is serious. आणि याच्यात एक आपण हे करतो की समजा व्हेन यू आर वर्किंग इन द बिहेवियरल सायन्स, ट्रीटमेंट ऑफ PCOD इज अ बिहेवियरल सायन्स. मग ते ह्या बिहेवियरल सायन्समध्ये एकच माणूस असा घरातलं तुम्ही पेशंट म्हणून तुम्ही त्याच्याकडे पाहिलं, इज गोइंग टू लिसन? त्याला करणं शक्य आहे का? की समजा माझ्याकडे एक पेशंट आला, ती बाई आली आणि ती म्हणाली की बोला असं असं आहे, आणि तिला आपण जे असंच करतो ना, तिलाच ॲडवाईस करतो आपण. इफ इट इज अ बिहेवियरल सायन्स, यू मस्ट इन्व्हॉल्व ऑल द मेंबर्स इन द फॅमिली. सो माय कन्सल्टेशन इज ऑलवेज अ फॅमिली कन्सल्टेशन. शी इज सिक बिकॉज ऑफ यू. शी इज सिक बिकॉज यू आर नॉट वर्किंग वेल, यू आर नॉट ॲडवायझिंग वेल, यू मस्ट करेक्ट. म्हणजे असं कधीच होत नाही की आपण घरामध्ये बसलो आणि चहा घेतोय आणि त्याच्यावर बिस्किटं खातो आहे. मग त्या पिरियडला सांगायचं तू चहा बिन साखरेचा घ्यायचा आणि बिस्किटं खायची नाही. आणि बाकीचे 4 जण घरातले बसले त्याच टेबलवरती चहा बिस्किटं खातात. इज इट पॉसिबल? मग तिने करावं यासाठी तुम्ही काय सांगितलं पाहिजे की सगळ्यांनी बंद करा एक. आणि सगळ्यांनी बंद करा. मग त्याच्यानंतर लोक काय म्हणतात, आम्हाला का शिक्षा? बरोबर आहे. म्हणजे तुम्हाला तर ते उपयुक्त आहे का? तुमच्यासाठी देखील ते तेवढंच वाईट आहे हे आपण जाणीवपूर्वक प्रत्येक वेळेस सांगितलं पाहिजे. आणि मग माझे डॉक्टर मित्र मला म्हणतात की डॉक्टर ते तुझं कसं काय ऐकतात लोक, मला काय माहीत नाही, तुझ्याकडे काय येतात हेच आम्हाला कळत नाही म्हणे, आमचं तर कोणीच ऐकत नाही. म्हटलं समजा एखाद्या डायबिटीसच्या पेशंटला तुम्ही एखादी गोळी सुरू केली, किती वेळा सांगता होती गोळी घ्या म्हणून? लिहून देता ना, तोंडी नाही सांगत, लिहून देता गोळी. नंबर असतो वरती, रजिस्ट्रेशन नंबर, खाली सही असते, बरोबर ना? त्याला थोडी वेटेज तुम्ही देता. आणि असं किती वेळा सांगता? 100 वेळा तरी सांगता. डायटरी ॲडवाईस किती वेळा सांगितलं तुम्ही? विच इज बेटर, विच इज इफेक्टिव्ह, विच इज सायंटिफिक. मग जोपर्यंत तुम्ही जितक्या वेळा औषध सांगता तितक्या वेळा लाईफस्टाईल मॉडिफिकेशन सांगत नाही, तो पेशंट तुमचं कसं ऐकणार? का तुम्हीच लाईफस्टाईल मॉडिफिकेशनला किंमत दिलेली नाही आहे. द प्रॉब्लेम लाईज विथ द डॉक्टर्स. वी अंडर व्हॅल्यू द इम्पॉर्टन्स ऑफ लाईफस्टाईल. आम्हाला कल्पनाच नाही, आम्हाला माहीत नाही, आम्ही याच्यात काय सांगायचं आहे. मग एकदा माझा एक गमतीशीर प्रसंग सांगतो. एकदा माझं एक प्रिस्क्रिप्शन गेलं आणि त्याच्यामध्ये लिहिलं रात्रीच्या वेळेस बोंबील, सलाड, भाजी आणि भाकरी. एका डॉक्टरचा फोन आला. त्या आधी त्या पेशंटशीच तो काहीतरी गडबड करत होता. असला कसला डॉक्टर आहे, त्यांनी बोंबील लिहिलं आहे. मग तो पेशंट जरा म्हणजे मला मतदान करणारा होता. मग त्याने तिथूनच मला फोन लावला की डॉक्टर, हे डॉक्टर असे म्हणतात. म्हटलं का? मी त्याला म्हटलं का रे बाबा, म्हणजे तो माझ्यापेक्षा म्हणजे माझ्या विद्यार्थ्याच्याच वयाचा होता, त्यामुळे मी त्याच्यावरती रागवण्याचा काही अधिकार नव्हता मला. मी म्हटलं का बाबा, माझं काय चुकलं मला सांग. तो म्हटलं बोंबील कसं काय लिहिलं? म्हटलं पेननी लिहिलं. काय अडचण आहे म्हटलं त्याच्यामध्ये? त्यांनी म्हटलं बोंबील कसं लिहायचं असतं का? काय अडचण आहे? जर तुम्ही एखादी गोळी त्याची 0 इफेक्टिव्हनेस असेल, महाग असेल, तू जर लिहू शकता, लिहिण्यामध्ये तुम्हाला फार अक्कल आहे असं तुम्ही स्वतःला समजता, आणि ती गोळी जर महाग असेल तर डॉक्टर मोठा असा पेशंट समजतो, तो त्याला ओमेगा-3 सप्लिमेंट मी काय द्यायचे सांगा म्हटलं मला. मग मी ओमेगा-3चे कॅप्सूल लिहायच्या का? दे आर कॉस्टली. माझा पेशंट शेतकरी समाजातला आहे, तो मग नॉनव्हेज खातो, बोंबील त्याला आवडतात. बोंबील पाहिले की ते तोंडाला पाणी सुटतं. हे विचारले की त्याला म्हणलं विचार त्या पेशंटला. तो हा डॉक्टरने विचारलं बोंबील खाता का, बोंबील आवडतात का, घरी करतात का? मग 400 रुपयाचे किलोचे बोंबील आहेत, त्याच्यामध्ये ओमेगा-3 किती असतं, प्रोटीन किती असतं, आणि याच्यापेक्षा चांगलं तुमचं आहे का? सांग म्हटलं मला. मग मी काय सिकॉड ऑइल जर लिहिलं असतं तर तुझं काही ऑब्जेक्शन नाही म्हटलं. मग सिकॉड ऑइल चांगलं की बोंबील चांगले? कोणी सांगावं मला. विच इज चीपर, बेटर अँड सायंटिफिक. मग आपण त्याला प्रतिष्ठा नाकारली, मला असं म्हणायचं आहे. पेशंटला समजेल अशा भाषेत सातत्याने या बाबीचा पाठपुरावा करावा लागेल. आणि मी त्याला एवढं म्हटलं की मी काय लिहिलं हा विषय सोडून दे, हे जे पेशंट 4 महिने करतोय त्याच्यानंतर त्याला बरं वाटलं की नाही हे तर विचार आधी. मला शिव्या घालण्याच्या अगोदर, माझी टिंगल करण्याच्या अगोदर. पेशंट म्हणजे मला लय भारी वाटतं, माझ्या गोळ्या 90% कमी झाल्या, आय एम कम्फर्टेबल. म्हणजे बाकीचे जे काही जे असतात ते सगळं. तुझ्या बापाचं काय गेलं म्हटलं? मी बोंबील लिहिलं नाही तर सोरमई लिहिलं म्हटलं. तो ते डॉक्टर हॉटेलचा मेनू लिहितात. म्हटलं बोंबील कुठल्या हॉटेलमध्ये मिळतो मला सांग म्हटलं. कुठल्याच हॉटेलमध्ये बोंबील मिळत नाही सर. म्हणजे आपण नको त्या गोष्टीमध्ये प्रतिष्ठा घेतो आणि आपल्याला काही सायन्समधलं माहीत नाही, याच्यामध्ये आपल्याला अप्रतिष्ठा वाटतच नाही आहे. वी मस्ट चेंज आवर पॉईंट ऑफ व्ह्यू, असं मला म्हणायचं आहे. आणि वन्स यू नो दॅट इट इज करेक्ट, यू स्टेक टू दॅट, कम व्हॉट मे. मी जेव्हा प्रॅक्टिस सुरू केली, मी तुम्हाला सांगतो, पुण्यामध्ये खूप लोकांनी माझी टिंगल केली. म्हणजे हा खरंच MD आहे की नाही इथपर्यंत चर्चा झाली. मी सांगतो तुम्हाला, म्हणजे उपहास, टिंगल, अपमान हे सगळं झालं. पण मी म्हटलं नाही, मी चुकतो त्याच्यात, मी बोलतो त्याच्यात काय चुकत असेल तर मला सांगा, बाकी बडबड नका करू म्हटलं. माझं काय चुकलं की नाही हां हे सांगा. आणि वी ऑल कन्सिडर इज अ टेम्पररी, की माझं PCOS आहे आणि ते बरं झालं म्हणजे संपलं असं नाही. द शेड्यूल हॅज टू बी कंटिन्यूड फॉर लाईफ, हे लक्षात घ्या. आणि सुपरस्टिशन सगळ्या लेवलला, सोमवार, गुरुवार, शनिवार आम्ही खात नाही, हे त्याच्यातलाच भाग आहे, बरोबर. आणि we need to change as a family. All these things apply to मी आधी बाकी बोललोच याच्यामध्ये. आणि challenges to follow. Gestational diabetes is a continuation of PCOD. Type 2 diabetes in adult is a continuation of PCOD. एवढं तुम्ही लक्षात घ्या. All the other associated disorders are a continuation of a same underlying mechanism, continually extended because we fail to interact. I mean, we fail to change. Right? हे पुन्हा तेच हे सांगितलेलं आहे. आणि त्याच्यामध्ये एकच आहे की लीन PCOS हा एक तुमचा सगळ्यांचा महत्त्वाचा भाग आहे. द पॅथोपॅथॉलॉजी सेम. त्याच्यामध्ये एकच एक नवीन रिसर्च माझ्या वाचनाला होती, लास्ट लाईन दिलेली आहे. पोस्ट रिसेप्टर सिग्नलिंग हे टाईप 2मध्ये नसतं किंवा तुमच्या PCOSमध्ये नसतं, पण लीनमध्ये दे आर स्टडिंग फॉर पोस्ट रिसेप्टर ॲबनॉर्मॅलिटीज. दॅट इज अंडर रिसर्च बेसिकली. दे आर लीन कॅरिंग insulin resistance. The only thing what they have studied in research is their fat cell number is less. So there is less space for storing fat. Right? That's why there is only difference. Otherwise the approach and treatment and management and outcome are same. No. आणि हा एक सगळ्यात महत्त्वाचा प्रश्न असतो की सर तुम्ही इन्सुलिन रेजिस्टन्स सांगता आणि टाईप 1 डायबिटीसमध्ये तर इन्सुलिनच नसतं. बरोबर आहे ना. म्हटलं इन्सुलिन नसतं असं नाही, तुम्ही बाहेरून टोचत असतं ना सकाळ दुपार संध्याकाळ. त्याचं काय, बिकॉज वी ॲडवाईज हाय कार्ब डाएट 6 meals a day for this patient over a period of time so as to control the hyperglycemia because of the food that you are eating. You need to give more frequent insulin, more higher doses of insulin. That's why maybe after 20 something, at the age of 20, they develop something called as double diabetes. That is called as double diabetes. You originally have got a insulin deficient or no insulin, that is type 1 diabetes, and because you are eating well, you are giving more insulin, that leads to insulin resistance. So you suffer doubly. All other things are same. Treatment, approach, outcome and everything is same in lean PCOS and type 1 diabetes also. This is extremely important. You understand your responsibility. In the field, there are only drug representatives, that is DR. Our short form is DR, doctor. You need to be HR, that is health representative. We must understand, especially the gynecologist. You can do much better social service by treating the patients scientifically. Huge scope, huge role and huge impact on the life of the individual, family and society overall. There is no drug for it, I repeat again, and we don't need it anything either. You can't sell it, that's why no one can buy it, right? We all need to change, and it's already late, right? And dare to be wise. As famously Gandhiji said, be the change that you want to see in the world. We need to change. Thank you.
Hello. And now we declare the oration to be over, and I request Dr. Kanse to be still on the stage because we will have few questions from the audience. Till the audience prepares the questions, you already have actually elaborated that even lean thin patients with PCOS, they may not show insulin resistance on any blood test, but still there is a post-receptor defect. So do you mean to say that all these patients would be benefited, they are already lean and thin, would be benefited by what dietetic advice or what medicine prescription, as far as correction of PCOS is concerned? Sir, Mike, please.
The approach remains same. Why I added that last slide is because I came across a research which hypothesized the post-receptor this thing. Why there is a post-receptor anomaly is yet being investigated. It is too early to comment. Till you get a further information, the approach should be same.
I have one question. What is that A1, A2 link?
In my word is a bullshit.
And how the chewing gum is bad? I mean,
Because it contains microplastic.
okay.
It contains artificial sweeteners that promote dysbiosis, that is small intestinal bacterial or SIBO. It is known, and there is something called as a basal level of insulin secretion. And there is something more, one more thing is the cephalic phase of insulin secretion. It's not post-meal, it is cephalic and basal level. So all these artificial sweetener enhances the cephalic phase. Because when something tastes sweet, the signal goes to the brain and then the insulin is secreted.
So no artificial sweetener also should be used.
दालचिनी एकदम छान आहे.
Bye.
Yes, sir. As far as this diet is concerned, असं सांगितलं जायचं की तुम्ही प्रत्येक घास 32 वेळा चावून खा, कारण as long as we eat, that will decrease the hunger. Okay, and the same principle is used by those who are the proponents of chewing gum, that you eat chewing gum for a long time, so there is something in the mouth, so you don't feel hungry and you don't feel like eating more.
No, because the chewing gum especially is a microplastic and artificial sweeteners and cephalic phase of insulin secretion. All the three fronts it is bad. No one should have. And chewing any food for that matter, एक 32 वेळा चावा आणि मग गिळा. म्हणजे याचा तुम्ही आर्टिफिशियल इंटेलिजन्सला जरी विचारलं किंवा गुगलवरती सर्च केलं, देर इज नो सायंटिफिक एव्हिडन्स. व्हॉट वी थिंक इट हॅज टू बी जस्टिफाईड बाय सायन्स. म्हणजे एकच आहे त्याच्यामध्ये की युअर सटायटी सिग्नल that you are full is sent by the brain. That's what I said. There are K cells in the duodenum, second part of the duodenum, and there are L cells in the jejunum. That sends you the satiety signals. And it takes around 20 minutes to reach to that L cells. मग तिथे जाईपर्यंत तुम्हाला खाल्ल्याचं हेच वाटत नाही. That's why it is important. So you must eat slowly. That's the correct thing.
Sometimes our patients need a proof that they have insulin resistance before we advise them something. So we have been doing home IR testing. We test their fasting sugar and fasting insulin. And then when I discussed with you, you said then get their C-peptide done, which will be more useful. But whatever the few cases we did, we found that those patients had high home IR and normal C-peptide.
This is very common finding. See, if you have some other test, it means the previous test is not sufficient. Now there is a called as lipo-IR, adipo-IR. Basically, the insulin resistance, where does it start first? Is in the adipose tissue. So you measure a free fatty acid level that we do not measure normally, and in millimoles per liter, which is normally 0.3 to 0.6 millimoles per liter, multiply it by insulin levels microunits per liter. नवीन टेस्ट आली याचा अर्थ पहिली टेस्ट सफिशियंट नव्हती. हां, म्हणजे माझ्या मागे याच्या मेडिकल कॉलेजच्या एका कॉन्फरन्समध्ये मी होतो आणि त्यांनी सांगितले की तुम्ही इन्शुलिन फास्टिंग करा. म्हटलं व्हॉट इज द वे द इन्शुलिन इज सिक्रेटेड बाय द बॉडी. सो इट इज अ म्हणजे सिम्पल हार्मोनिक मोशनमध्ये सायक्लिकल पॅटर्नमध्ये असेल. व्हॉट इज द ड्युरेशन ऑफ द सायकल अँड व्हॉट इज द डिफरन्स इन द ॲम्प्लिट्यूड. इट इज अराउंड 3 to 5 minutes. म्हणजे तुम्ही एक लेवलला जर इन्शुलिन चेक केलं नेडेलला, म्हणजे खाली जेव्हा येते तेव्हा केलं तर यू विल फाइंड अ लोअर लेवल, आणि वरच्या लेवलला केलं तर यू विल फाइंड अ हायर लेवल. सो यू नीड टू डू 2 टेस्ट. अरे म्हणतो करायचं बरोबर आहे, पण पैसे कोण देणार एवढे? ते टेस्टला 1000 रुपये जातात आणि पेशंटला 2 वेळा टोचायला पेशंट फक्त इन्शुलिन लेवलसाठी 2दा. इट्स नॉट ॲडवायजेबल. मग त्यापेक्षा सी पेप्टाईड बरे, कारण देअर फ्लक्च्युएशन्स आर व्हेरी लेस. पण व्हाय डू यू नीड अ टेस्ट IR measure? You don't need a test. There are clinical parameters, there are surrogate markers like high triglyceride, isn't it? Simple marker, low HDL is simple marker. You see clinical markers, many, plenty. त्या मॅडमना काय विचार.
Down legumes and pulses, how will they get enough proteins apart from dairy products?
Apart from dairy?
So if they, milk, but how much milk can an adult have? And if we are asking them to increase exercise, but cut down legumes and pulses, which normally for vegetarian people give good protein, as far as my knowledge.
Good. I don't agree with the good protein.
But what would give them good protein then?
You can add paneer. You can add chakka.
But just
nuts,
dairy basically.
Simple shengdana. 25% proteins. Khobra, again around 20% protein. Badam, 25%. Akroad, 25%. These are the sources. You mix and match. I am not saying that you need only animal source, but you will be better with the animal source.
Yeah, no, it just if somebody is vegetarian.
You can add nuts. Nuts is a good solution.
Thank you.
And soya chunks, de-oil cake, DOC, not soya, soya chunks.
Dr. Kandse, if I have to sum up everything in just one word, if I am required to. He is a terrorist.
Thanks for that.
You will never get a straight answer, sweet, goody answer. We are so enlightened and happy to have you for the Shirodkar oration. Both the oration and the society, we say that we really got a person who is most deserving to come to Solapur for this oration. Now I hand over the proceedings to the executives of the society.
On behalf of Solapur OBGY Society, we would like to thank Dr. Kandse sir for his eye-opening lecture and totally new perspective on metabolism and PCOS. I would like to request our President Dr. Neeta Ghate Madam to felicitate him by presenting a silver plaque and citation. I would like to invite Dr. Dabde sir, Dr. Bahubali Doshi sir, Dr. Lalita and Dr. Chandrakant on stage.
Late Dr. V.N. Shirodkar Oration Year 2025. On Sunday, 6th April 2025, late Dr. V.N. Shirodkar Oration, we are honored to felicitate you, Dr. Chandrakant Kandse sir. Sir, you are a distinguished physician, a dedicated teacher, a passionate social reformer. Your pioneering work in diabetes reversal has transformed patient care. Your expertise in metabolic management of PCOS has provided a new hope to many. With 38 years in internal medicine, you have touched thousands of lives. As a professor for over 24 years, you have mentored and generations of the doctors. Your leadership in healthcare and social service through 3 renowned NGOs has made a lasting impact. Your contribution to disaster relief and medical outreach reflect your deep commitment to humans. SOGS proudly presents you with this prestigious award in recognition of your excellence and lifelong dedication. We express our deepest gratitude and admiration for your remarkable journey and inspiring legacy. Thank you, sir.
I would like to invite everyone for lunch.
Thank you everyone for attending. Please join for lunch.